Dr. Lots, make me co-host again so I can record. I think we got knocked off. Please.
Dr. Halasa, you're muted.
Okay, since when I'm muted? Okay. All right, so now can you hear me, guys?
Yes.
Okay, so insulin resistant is the culprit. Insulinemia is the problem that create the whole problem that we currently have experience ourselves. You can say 90% of adult population do have it, even though their glucose and hemoglobin A1C could be normal. And so we want to target that. We want to increase insulin sensitivity, and we want to lower the insulin because insulin can lead to inflammation, can lead to visceral fat, and visceral fat can lead to more inflammation, interleukin-6, which leads to more resistance. And insulin resistance and inflammation and free radicals, along with stimulation of mTOR by insulin, can put us at risk of having cancer. Adding all the other factors that we are being exposed to, which is the microplastic, COVID, toxins in our food, which is estrogen mimics, all of this will add electromagnetic wave, like Dr. Juicy was talking about. All of the stressors will add together, and it will lead to all the manifestation of insulin resistant, or in the form of estrogen dominant syndrome, or in the form of mast cell activation syndrome. They all overlap. And it leads to those brain fog, fatigue, tiredness that I think everybody's experienced. And we need to change that by looking at our diet, by exercising. And so I create a book for this. It's called Metabolic Codex. And Dr. Goldman and Klatz and Dr. James is the co-authors of the book. And they're going to review it, and we're going to be releasing it soon. And I want everybody here to focus on this problem. The abstract of this problem that we have, that metabolic syndrome affects 1 billion people globally, and it's causing 2 million people to die every year. Hyperinsulinemia, not glucose, precede diabetes by 10 to 15 years. So you can have insulin resistance and insulinemia and your body is being destroyed because of the free radicals that insulin is stimulating, the NOx enzyme, and also it's compromising the mitochondria, releasing these pathological free radicals that leads to acceleration of aging, that leads to cortisone dominancy, And cortisone dominancy leads to insulinemia and insulin and metabolic syndrome. And they feed each other, by the way. Those three culprits that we know: estrogens when it's high, and which leads to estrogen dominancy, and insulin, hyperinsulinemia and insulin resistant, and the cortisone. They all feed each other, and they lead to even shifting the immune system to Th2, which leads to mast cell activation syndrome. And all those syndrome overlaps. All this syndrome leads to increased risk of cancer, accelerating of degenerative diseases. Alzheimer leads to all these chronic diseases, including aging itself. So this lecture outlined the mechanism linking insulin to excess cardiovascular dysfunction. As we know, it starts with oxidative stress because it stimulates the NOx, compromises the mitochondria, release of pathological free radicals, leading to visceral fat, which leads to interleukin-6 production. All this inflammation leads to further insulin resistance. Inflammation leads to degeneration of all degenerative diseases, including Alzheimer and many others. And it leads to immune dysregulation, shifting to Th2 and Th17, which compromise the immune system, which is Th1 cytotoxic T cells, that leads to, killing the cancer. It leads to redox collapse. Yes, you will have more pro-oxidant versus antioxidant. It leads to triggered cancer. And even if you have cancer and you have insulin resistant, it leads to cancer progression. And it leads to putting your risk at having COVID infection. And also, COVID itself and spike protein can aggravate the insulin resistance as well, because as we know, COVID spike protein, it inhibits the ACE2, and ACE2 is an antioxidant enzyme, right? It converts angiotensin 2 to angiotensin 1,7. And so if you block that pathway, you block the antioxidant pathway, you end up with pro-oxidant pathway. And more free radicals, more interleukin-6, more shifting to Th17 and Th2, and more oxidation of insulin resistance. And so they feed each other. They overlap. They trigger each other. And so shifting the immune system to Th2 and increasing interleukin-6 will activate the mast cells, leading to mast cell activation syndrome. And even the manifestation of all those syndrome, estrogen dominancy, cortisone dominancy, mast cell activation syndrome, post-COVID syndrome, they all overlap, feeding each other, this estrogen and cortisone dominancy. And hyperinsulinemia, which leads to insulin resistance, which leads to metabolic syndrome. And when you damage the endothelium, what will happen? When you damage the endothelium, you don't have much of nitric oxide, your blood vessels become rigid, you end up with hypertension. When you have too much of insulin and you're not breaking down the fat tissue in your viscera, what will happen? You end up with obesity, right? All right, so those are the metabolic syndrome components: obesity. What else? Obesity, hypertension, and you will have high triglycerides and high fat in your blood. And it's all because of the insulin resistance. And those fat will be oxidized by the free radicals that's generated from the insulin stimulating the NOx. And those oxidized LDL will deposit into your blood vessels and form the foamy plaques that the macrophage are eating inside those blood vessels under the endothelium. You end up building up those plaques from this foamy macrophage with all this oxidized LDL, or low density lipoprotein, right? And this inflammation that's being released from the macrophages, which is mostly they are interleukin-6, they will promote fibrosis. So your blood vessels will also get fibrosis, plaques, and because of damage of endothelium and releasing the endothelin-1, this will lead to activation of the platelets, leads to stroke, to heart attack, and to all the complications of the diabetes. And so we can start that insulinemia, insulin resistant leads to oxidative stress. Oxidative stress and free radicals leads to endothelial dysfunction. Endothelial dysfunction leads to hypertension. Insulin stimulates the mTOR, and it's a bad combination. When you have stimulation of mTOR and free radicals, what's that mean? Means cancer, right? Growing and free radicals that will mutate those DNA. You end up putting your patients at risk of cancer. And insulin increases IGF-1, which stimulates the growth, of course. Insulin shifts the immune system away from Th1 and cytotoxic T cells, so it compromises the immune surveillance against infection, especially the intracellular pathogens and like virus and cancer, and put us at risk of cancer, right? When you compromise the cytotoxic T cells. Same thing like COVID, spike protein, what it does shift the immune system to Th17 and Th2 and compromise the Th1 cytotoxic immune surveillance against cancer. So, and they all overlap. What about cortisone dominancy? Yes, cortisone too, when it's high, it shifts the immune system to Th1 and Th17. What about estrogen dominancy? It's the same thing. It shifts the immune system into Th1 or Th17 and put us at risk. So it is an urgent thing that we need to balance the immune system. And how we do it? First, address the insulin resistant. And it's not hard to do it. It's not. Wean patients from insulin if they are taking it and start increasing the muscle mass, giving them everything that helps to increase the insulin sensitivity, looking at all the free radical generators that leads to aggravation of the insulin resistant, that leads to free radicals, whether it's leaky gut, whether it is underlying inflammation, chronic infection, toxins, anything. You need to screen it. You need to work on looking for all those holes that leaks the free radicals in the body. Social stress. So if you apply the CDPM protocol, you will end up improving your fasting insulin. That's very important. And you will be improving your HOMA, which is the homeostatic model assessment of insulin resistance. And also, it's very important, this ratio of triglyceride HDL ratio. It's a very sensitive test for the endothelial dysfunction and for insulin resistance. So measure this, and you need to normalize it. Leptin, adiponectin. In the clinic, a lot of patients that you have, they say, I cannot stop eating. I feel hungry all the time. And we're missing something here. Why we don't measure the leptin adiponectin ratio? And if you measure, you will find out reason why they're hungry, because they have leptin resistant. All right. And when they have leptin resistant, so leptin, what is leptin function? When you eat and you have enough food and you stretch your stomach and your fat tissue is full and they are stressing, so they start releasing leptin. And leptin goes to the brain and tells your brain to stop eating. You're done. Our fat tissue is full of fat and your stomach is full, stop. But if you have oxidative stress and you have inflammation for any reason, or if you have insulin resistant, that leads to activation of free radicals, what will happen to the leptin receptors? They will be blocking. So you're not feeling satiety. You are hungry all the time because leptin is not able to stop your brain centers to say stop eating, or we are satisfied. And so the patient has no control. They say, I cannot stop it. I'm hungry all the time. I have to eat. I'm craving food. And the reason, because they have leptin resistance. All you need to do in your clinic is to prove it by just measuring leptin adiponectin ratio, which is easy thing to do. And if it's high, you can tell the patient, okay, the reason why it's high because of insulin resistance, because all the inflammation and free radicals that you have, whether it's coming from insulin resistance or coming from other things. It could be having mold or leaky gut or Lyme or, any other factor, infection, toxins, microplastic, post-COVID syndrome, mast cell activity, anything, right? All those are free radical generators. And they are causing your leptin to be resistant. And that's why you're not feeling satisfied, or the satiety center is being compromised now. What we need to do is to help to optimize your health. And we do all the things that helps to increase insulin sensitivity. That's the first thing to do. And once you do that, then the patient will stop eating, and he will end up eating normal and back to, and then you end up also advising him to having nice diet, low carb diet, exercise, and all of this helps to increase the expression of antioxidants and increase the leptin sensitivity. Once you increase the leptin sensitivity, the patient's satiety will become normal and he stops eating. But you need to tell the patient why you're feeling hunger. And patient will appreciate that, right? When you reason with him and say, hey, it's not your fault. You have a problem, and here's the problem. But if you don't give them that answer, why I'm different from others, why I cannot stop eating, why I'm obese and I cannot lose weight, right? It's because of the insulin resistance. And you need to crack that code. And it requires a lot of effort from both the doctor and the patients to break through this insulin resistance. What you will start to do, GLP-1 is a miracle. Everybody needs to start doing it because GLP-1 itself increases the sensitivity of leptin, and GLP-1 increases the insulin sensitivity, and the GLP-1 increases the endogenous insulin, so you don't need exogenous insulin. So GLP-1 helps to wean patients from insulin, the bad thing. You replace them with GLP-1, along with metformin and berberine, polyphenols, and looking for all the free radical generators that we talked about. And the patient has problem with sex hormone, you need to work on it. If the patient has too much of estrogens over estradiol, the ratio has to be at least less than 1. And if the estrogen is more than estradiol, then you have estrogen dominancy, right? And so we need to keep the ratio between estrogen and estradiol less than 1. That's a new formula for Stefan to start checking the ratio between estrogen and estradiol. There's a ratio between progesterone and estrone, which has to be above 100. But there's another ratio that you can add to your formula, which is the ratio between estrone and estradiol. Okay. So what will happen when you have insulin resistance? You have inflammation, right? Then, and you have, as a response to all of that, your cortisol will go up. When you have inflammation, your body responds by, can you hear me, guys? Yeah, okay. Your body responds, when you have inflammation, your body responds with increasing the cortisol, right? That's the response to inflammation that goes by diabetic resistance. So cortisol will come into the arena, and cortisol leads to what? Oh, it stimulates the beta cells to secrete more, or secrete. It stimulates your liver to release more of sugar. Remember that? Cortisol leads to hyperglycemia, right? And then hyperglycemia leads to insulin, and then insulin leads to inflammation. Inflammation leads to cortisol. So they are feeding each other here in a positive feedback loop. And then what will happen here when you have cortisol is high? The cortisol, when it's high, they cause the steal, or they will also stimulate the aromatase along with the free radicals and generate more estrogens. Okay, then you have estrogen dominancy, right? And low estradiol and low testosterone, which is not something good. And then what will happen to the estrogens? Estrogens stimulate the steal, which is the conversion of the cortisol, the conversion of cholesterol to cortisol. So instead of cholesterol going to give you 6 hormones, no, the estrone is a betrayal of the 6 hormones, and they stimulate the conversion of the cholesterol to cortisol, right? And you end up with the steal. Okay, so how you calculate the steal, the shifting from producing 6 hormone, which is regenerative drugs in your body, into cortisol, which is degenerative drug. And that's what's happening at the age of 50, right? The 6 hormone drops, the cortisol goes up, and degenerates your body in age. We need to stop that steal. All right, we need to stop it. How you stop it? By giving progesterone to counteract estrogen, right? And by feeding the gonads with DHEA, all of this helps. And by inhibiting the aromatase, by giving them DEM if they need it. And we do that, we can stop the steal and increase the 6 hormone and the regenerative effect. And so how we can measure the steal? There's a ratio, which is cortisone DHEA ratio. Okay, so that's another formula. I need you to add it when you are doing all your measurements for yourself and your patient, and you want to know, is there any steal, is there any movement from 6 hormone pathway going to cortisone, leading to cortisone dominancy and estrogen dominancy? Yes. What you need to do is just come up with a calculation of cortisone and DHEA ratio. Okay, so what will happen when you have too much of insulin? Insulin leads to lipogenesis, leads to more fat accumulation in your liver. So your liver the cells become full of fat. And you end up with non-alcoholic fatty liver. And non-alcoholic fatty liver is not something good, right? It's inflammatory. And your liver will start also, same like your visceral fat, releasing all the inflammatory signals. Plus, you compromise your liver function and clearing up the toxins from your body, because liver is a very important organ to detox your body, including the estrogen and the xenoestrogens. So it's very important to manage estrogen insulin resistance and to reverse the fatty liver, because in order for me to get rid from the excess of those estrogen mimics and estrogens is to regain the function of the liver. And so what you will see with patients with insulin resistance, you will see they have some liver function abnormal, really. And you think, oh, we're going to fix the liver. There's a liver problem. Well, it's not really the liver problem. It's the insulin resistance. Once you fix that, the liver goes back to normal, right? Not just that, insulin resistance leads to generation of free radicals, leads to stimulation of xanthine oxidase, the one that converts the purine into uric acid. And you will see high uric acid in those patients with insulin resistance. And so what will happen? This is what's happening in our clinic. We think, oh, uric acid is high, liver function is high. There's something wrong here. So the patient has gout, and maybe he has hepatitis or something. What's going on? Right? No, both is caused by insulin resistance. You don't need to do anything. Just fix the insulin resistance. Your liver goes back to normal. Your uric acid goes back to normal. You don't even need to give them allopurinol. Right? And wonder why, oh, this patient has liver problems, and he has gout and all that stuff, and it's a complicated case. Yeah, it's just start with insulin. Not just that, because of inflammation from the visceral fat, they may end up with microcytic anemia. They may end up with microcytic anemia because they increase the hepcidin, and that decrease the absorption of the iron, and they will manifest as anemia. Oh, patient has anemia, liver problem. And so this is what's happening even when we diagnose a car. There's a system, the mechanic puts it in the car, and you have codes coming up. And each code will refer, oh, you have a problem in this part, this code, and this problem in this part, and this part, right? And then what will happen is that, oh, God, we're going to change those parts. But those parts, actually, nothing wrong with them. Even if you change them, and the car is not working. Ah, really? So we need to integrate logarithm in those scanning of the car in a way that interpretate those 3 codes into one problem, one part that has nothing to do with those 3 parts. Okay, the human body works the same way. Insulin resistant leads to fatty liver, leads to liver enzyme to go up. Insulin resistance and oxidative stress leads to increase the conversion of purine to into uric acid, and increase the uric acid. We thought it's gout. Insulin resistance leads to inflammation and iron and inflammatory hypochromic anemia, cytochromic anemia, and we think that the patient has anemia. But the reality is that it's coming from insulin resistant, manifest in all those different body parts or body malfunctions or physiological, pathological malfunction, right? And it's only the problem is start or triggered by insulin resistance. And this is very, very important message, because there's a lot of cases out there that we are treating them as gout and they are insulin resistant. We're treating them that we think his liver has a problem and they are insulin resistant. We're treating them and giving them iron, which actually aggravates the problem more and more, iron, because it turns into ferritin, and ferritin is more inflammatory, right? You don't give them iron, those patients. Don't give them iron, because they have a lot of iron in their visceral fat stored there, and it's inflammatory. You need to move the ferritin back into ferrous from their inflamed tissue by decreasing the inflammation. Don't give them more iron for those patients. Don't give inflammatory anemia iron. But we do it because of lack of understanding of redox medicine and lack of understanding the importance and the crisis of insulin resistance. Today, we have the answer. And today, this answer needs to be propagated to all your patients, to all the doctors and your colleagues. Next Monday, we're going to talk about clinical cases. But I need you to bring your clinical cases after you test them. So we have 1 week. How many doctors do you have here? We have almost 18 doctors. I need cases to prove what we're talking about here is clinically visible and applicable and is true. And here's my patients. Here's the data. Here's the insulin resistance. Here's the liver function. Not just that, the insulin resistance leads to hypothyroidism because it causes inflammation in thyroid. And one will think, oh, let's go ahead and fix the thyroid, giving that, giving them, they give them NAD and they give them, what's the other drug we give them to balance the immune system? We give them thymosin, beta and alpha, LD. What's the LD? What is the drug that we give for immune modulator all the time to balance the immune system? LDN, right? And the reason inflamed the thyroid is because of insulin resistant. So if you give them LDN, yeah, it works, it balances, but you're not into the root cause. So even your thyroid, the patient has hypothyroidism, microcytic anemia, his liver is malfunction, hypertension, and he has gout, right? And we think that we start treating them separately. And the reality is that they all root into insulin resistance. And that's why, Stefan program, if I summarize it, and I sum it, it's actually a treatment for insulin resistance. Everything that Stefan does is managing metabolic syndrome. But we need to have specialists, because endocrinologists fail. They are healthcare providers, and they do whatever the big pharma tells them to do, give them more insulin. And they don't think. They're not allowed to think. If they think, they lose their license. They're healthcare providers providing what the big pharma tells them to do. We don't have that control as integrative doctors. We're looking for what's best for the patient. Okay? So, hyperinsulinemia appears before glucose rise and before hemoglobin A1C increase. It is very important because the damage of the blood vessels is caused by insulin for 10 years, and it manifests after 10 years, and we can stop it. Why we have to suffer from the consequence of our ignorance of preventing the damage and the cardiovascular disease in the beginning. You cannot practice anti-aging and you have insulin resistance. Does not make any sense. You cannot practice anti-aging to a patient and patient has insulin resistance, and you're giving them metformin or you're giving them rapamycin, that's bullshit. So that's the reason those anti-aging fail, because they don't optimize the health of the patient. It does not work, anti-aging. Anti-aging, slowly the process of aging happen after you optimize the health, especially the insulin resistant. And after you detox the body, you normalize the sex hormone, and then you go ahead and you give them exosomal stem cells, and you give them those growth peptides, and you give the growth peptides after you're clearing the senescent cells, and don't just give growth peptides. And they are full of senescence and cancer cells and inflammasomes. And that's why, giving those growth factors or growth peptides needs to be done by profession who understand the cycle of inhibition of mTOR and then stimulation. You have to go through the cycle. Fasting is one way, 16 hours fasting, 8 hours of eating. A cycle of cleaning the body, mTOR inhibition, stimulation of autophagy, and then you give them the peptides and exosomes. So hyperinsulinemia leads to visceral fat, which is a disaster. I think everybody above 50 experiences visceral fat, and this is the visceral fat. A lot of fat inside the adipocytes, and the fat leads to hypoxic in those cells. Hypoxic leads to compromising the mitochondrial, inflammation, generation of interleukin-6 and free radicals. So source of inflammation in your body is that visceral fat. That needs to be over. If you see somebody with visceral fat, you have insulin resistance. There's no question. Oh, my glucose is normal. My hemoglobin A1C is normal. But yeah, your insulin is eating your blood vessels. And you will end up aged, and you end up with cardiovascular disease and stroke and all that stuff. And then there's this patient with visceral fat. They say, I want to do anti-aging. Oh, okay, we'll give you all this anti-aging therapy. Will not work. It's a waste. Okay? Your fat has to be gone, and your muscle has to grow before you think even doing anti-aging or slowing the process of the aging. We know the insulin resistance leads to free radicals and damaging the endothelium, which leads to high blood pressure. So all the metabolic syndrome components is caused by insulin resistance and insulin. So metabolic syndrome, who creates the metabolic syndrome? Insulin. When it's high, when it's normal, it's good. We need some insulin because Sifan would say insulin is anabolic. I need it. Yes, you need it, but you need it in a spike, not chronic constant high, in a spike, right? Anything growth factor constant high is disaster, especially if it stimulates the free radicals like insulin does. And we know it causes inflammation, especially Th17 mediated inflammation. It leads to endothelial dysfunction. And when you have endothelial dysfunction, what will happen? Your blood vessels will leak all this low density lipoprotein, oxidized LDL, forming a plaques, foamy macrophages full of oxidized fat, generating interleukin-6, stimulating the fibrosis. So your blood vessels is narrowed by fibrosis, by the fatty plaques and macrophages, and by the clots. And eventually you end up with a stroke and gangrene and angiopathy and retinopathy. And when you damage your endothelial cells, endothelial, we know, is a source of nitric oxide. Your nitric oxide withdraws. And if your nitric oxide drops, that will lead to further insulin resistance because nitric oxide is an antioxidant. And it's very important to maintain the vasodilation of the blood vessels. If it's low, you end up with vasoconstriction. You end up with hypertension. That's why Dr. Nathan all the time, nitric oxide, yes, nitric oxide, anything that helps increase the nitric oxide in your body, it's very important to keep your blood vessels compliance normal and prevent you from having hypertension. So the target is to increase the insulin sensitivity. Now, what you need to do, everybody here needs to start measuring the fasting insulin, fasting glucose, yes, and do the hemoglobin A1C, right? Must clinic measure the fast glucose and hemoglobin A1C. That's what we are trained to do in medical school, internal medicine doctors, endocrinologists. That they don't even look at insulin because they don't see it insulin as a culprit at all. In fact, they are giving them insulin. When the hypoglycemic drugs does not work, they give them insulin. And they give them more poison. And this is being overlooked by the medical community. Today, we know the importance of weaning patients from insulin, managing insulin resistance, and normalizing the physiologic. And the best way of doing it, especially a patient who has diabetic type 2 and on insulin, is to give them GLP-1s. But GLP-1s has side effects. What are side effects of GLP-1? It leads to delay in gastric empty. GLP-1, which leads to malabsorption of nutrition, especially B12 and others and vitamins. So you need to supply that. And then because of the GLP-1 cause shrinking in the fat very fast, as you know, because it increases insulin sensitivity and it increases the leptin sensitivity. That's why you feel, I'm not hungry anymore. I don't need anymore, which is a good thing, right? And it drops the leptin because of that. And leptin is a very inflammatory agent, by the way. So shrinking fat very fast, what will happen? You release all these fat-soluble toxins, the teflones and all the fat-soluble toxins and microplastics, and they will toxicate the liver, toxicate your kidney, and that's why the patient feels nausea and vomiting and say, I can't take it. No, it's just, I feel so nauseated because of irritation of the liver from those toxins being released. So that's the reason I all the time asking the compounding pharmacy to develop a version of cyclodextrin-loaded GLP-1. So the cyclodextrin does the work of high-density lipoprotein and clear the body from these fat-soluble toxins that's being released. Whether it's microplastic, Teflon, all those petrochemicals, byproduct, xenoestrogens, oxidized cholesterol, all those things, and clear the blood vessels as well, the plaques, by cyclodextrin. Now, did I find the right compounding? I'm going to talk about it after the CME. Okay. So everybody measure your insulin fasting and also come up with that calculation we talked about, the homeostatic model of insulin, assessment of insulin resistance, which is multiplying fasting glucose, multiply fasting insulin, divide with 405. Okay. And what is the metabolic range of hemoglobin A1C? How much you want it? We want it to be for hemoglobin A1C less than 507. Well, the mainstream medicine does that, right? Above 6.5 is bad. And what is hemoglobin A1C? It's glycan, it's oxidized sugar. So when you have high sugar, they got oxidized because NOx enzyme is being stimulated by the insulin. So you have too much pathological free radicals react with the glucose, give you glycans, and those free radical generators, and they will manifest in a form of high hemoglobin A1C, which is glycans, oxidized sugar of the protein of the hemoglobin. And you will be diagnosed pre-diabetic if your level is 5.7, 6.4, and you're full diabetic if you're above 6.5. What we don't measure is fasting insulin. That needs to be reinstated in every clinic. Every doctor here from tomorrow, measure your fasting insulin, including yourself. And we need the sugar to be less than 100 milligram per deciliter. Sugar between 100 to 125 is pre-diabetic. Above 126 is diabetic. Fasting insulin ideal is 3 to 6 micro international unit per mil. If it's above 8, it's not good. That's early pathology. I think everybody here is going to be above 8, except Stefan. And I'm sure that my fasting insulin is above 12, so it's a severe hyperinsulinemia. And that needs to be stopped, okay? We need to lower the fasting insulin. We need to lower the HOMA to less than 1. Above 3 is pathologic, and most of us are above 3, the HOMA, which is the multiplication of fasting glucose insulin divided with 405. Okay, so those numbers we talked about last time. We said we're going to talk more technical, and I need all the doctors here to be technically interpreting the labs and start doing your fasting insulin. And next Monday, we're going to have cases. So please, Dr. Joseph, Stefan, everybody here, please, even you doctors here, I needed you test yourself. And then let's report all those testing, analyze them, and finding out what will be the best personalized solution. Now, best personalized solution is not a copycat. Everybody takes metformin or takes a GLP-1, all that stuff. We're going to personalize it based on your whole data, all your lab, all your history, all your physical. You give it to me, I put it in my AI, and I will exactly tell you exactly what you need. And especially if you come up with genetic testing for all the SNPs related to this metabolic syndrome, which we're going to talk about it on Monday. So you give me all the results of the SNPs, all your lab, all your history and physical. I put it in my AI program, and I tell you exactly what you need to override and overcome the problem that you have. And I did help a patient. She called me and she said, "Thank you very much. I feel so great." And I think you can do the same. So, epidemiology of metabolic syndrome. When we know the components of metabolic syndrome, it's central obesity. And in Japan, you know that if your central measurement of your abdominal circumference, if it's above the norm, you're not qualified to work in Japan. Same thing we did with no smoking inside the public area, and we reduced the number of people smoking almost dramatically. That's in America, almost 50% drop or more. Japan is doing the same policy, but with abdominal circumference. And so there they have to be fit. Can we apply this rule here in the United States? Better than the rule of imposing vaccine, by the way. It's more dramatically would help the health of everybody here, especially in the United States. We have more than 70% obesity rate. Waist circumference. The man has to be what? Above or how much they have to be? Less than 102 centimeter, right? Women has to be less than 88 centimeter. I think, Stefan, you are less than 100. Me, I think I'm 150 for sure. So any above 102 is not good. Above 88 for women is obese. And the target here is to be less than 94. I don't know about you, Stefan. Did you measure your waist?
It's 32.
What?
Or it's like 30.
Inch, not in centimeter.
Uh,
Yeah, so I need everybody, when you
maybe-
come next time, I need your measurement of your waist.
Okay.
Because if your waist is not optimal, you don't even need to do insulin resistance. You have insulin resistance. So it's so simple. Just measure the waist. And if it's above 102, you have insulin resistance. All right. So sometimes you don't have the lab, and you know you are somewhere remote area. You have abdomen and you have visceral fat. Your abdominal circumference is above the norm, above 102. You have insulin resistance. Let's start working on getting that fat out. I need that myself. Okay. Of course, the metabolic syndrome part of it is hypertension. We know the insulin resistance leads to free radicals, and then the free radicals leads to damage in the endothelium, and then you end up with endothelial dysfunction, and you end up with hypertension, right? So we are hypertensive if our blood pressure is above 130, above 130 over 85, right? Optimal has to be less than 120 over 80. pulse pressure has to be less than 45. Morning blood pressure for us as CDPM is good if it's less than 115/75. Insulin resistance, we need to be making sure we calculate it. And the fasting insulin has to be what? Less than 10. Above 10 is not good. Optimal 3 to 6. If you're above 12, you're in a bad shape. The HOMA insulin resistance has to be less than 1. If you are 1 to 3, you're on the borderline there, and you do have insulin resistant, and it becomes severe if you're above 3. I think I guarantee that everybody here except Stefan is above 3. And then part of the hyperinsulinemia and insulin resistance and inflammation, oxidative stress, it leads to dyslipidemia, right? Triglyceride has to be less than 90. It's high if it's above 150. HDL has to be above 55. Must, if women has to be more than 65. Women, if it's above 65 or less than 65, it's abnormal. Less than 40, it's abnormal for men, and we need to keep it for women above 65 and for men above 55. Hyperglycemia, late metabolic finding, fasting glucose has to be less than 90, and pre-diabetic if it's 100 to 125, and you're diabetic if you are above 126. But don't be fooled with your sugar and thinking that I'm healthy because my sugar is normal. The whole medical community, the mainstream medicine, the big pharma, and most of the public, that's what they think, including myself before 3 weeks. I don't know what hit me into the insulin, but I think we are being kind of fooled, or we are being ignorant, I think we can say, for lack of understanding the root pathology of metabolic syndrome. And now we know, so we need to fix it. So you need to keep your hemoglobin A1C less than 5.3, right? If it's above 6.5, you are in trouble. Okay, what's important marker in the dyslipidemia is the ratio between triglyceride and high density lipoprotein. This has to be normal. And if it's high, then you are in trouble. You have insulin resistance, you have endothelial dysfunction, and you have high risk of cardiovascular diseases. So the optimal is going to be less than 1.5. Very important to record this. And everybody needs to test it, because if you want to know whether you are at risk of cardiovascular disease and your endothelium is being damaged and you're having plaques and your blood vessels is narrowing and you will end up dying from cardiac attack or stroke or from all the complication, then measure this and make sure your TG, high density lipoprotein ratio, is less than 1.5. If it's above 3.5, you are in a bad risk and you need to work on and normalizing this ratio, especially increasing the high density lipoprotein. And trust me, cyclodextrin will do it. Cyclodextrin will clear all those bad fat, and cyclodextrin will help to increase the high density lipoprotein. So there is some supplement out there where you have curcumin loaded with cyclodextrin already available with alpha lipoic acid. Take those ones that's been loaded with cyclodextrin. I'm trying to get a nutraceutical company to load all their supplements inside cyclodextrin, with no luck yet. Okay. So the pathophysiology, hyperinsulinemia leads to lipogenesis, leads to accumulation of fat in your visceral fat. Your visceral fat cells will become hypoxic. Mitochondria is being compromised because it's full of fat. So what will happen? What will be released? What you expect from your visceral fat is a source of inflammation, source of interleukin-6, source of free radicals that damage your body. That fat tissue in the abdomen is the source of the inflammation. Remember the tire? And that has a hole? And I don't understand. You're going to slow the aging and the patient has visceral fat? That's no. You cannot do that. because that's like, okay, I'm gonna fix. I have two holes: the anti-aging hole, slowing the process of aging, and then I have visceral fat. Okay, I'm gonna learn how to plug the aging and slow the aging. Okay, but if you plug that tire with this hole, and you leave the fatty, the visceral fat, your tire will not work. You cannot have a nice tire and you have a hole leaking the free radicals inflammation. So think about the visceral fat is a hole that leaks into your body all the free radicals, including, again, you can have leaky gut syndrome as well, leaking lipopolysaccharides. And so you need to fix that. All of those free radical generators needs to be screened. Now, what will happen to hyperinsulinemia? It increases the visceral fat adipose tissue storage. It stimulates the NOx enzyme. That's the important pathological process, and increase the free radicals. And when you damage endothelium, what will happen? The endothelium start releasing endothelin-1. Endothelin-1 is vasoconstrictor versus nitric oxide, which is a healthy endothelial cells release, which is nitric oxide, which leads to vasodilation. If you damage endothelium, you end up with vasoconstrictor due to endothelin-1. And you can measure endothelin-1, by the way. All right, so what will happen? When you have inflammation and your fat tissue is releasing all those inflammation, your body will respond. Say, I have inflammation. How they respond? Increasing the cortisol, because cortisol helps to stop the inflammation. But okay, so what would happen when you increase the cortisol? You stimulate the release of sugar from your liver, and you end up with hyperglycemia. What would happen then as a response to hyperglycemia? More insulin. More insulin, more insulin, more stimulation of NOx, more generation of free radicals. So you end up with this loop of feeding. The insulin is feeding cortisone. And then not just that, then you produce more cortisone. Then you are stealing from the cholesterol. Instead of making 6-hormone, you're making cortisone. So what will happen to the 6-hormone? It drops. And if your 6-hormone drops, which is very important to stimulate the expression of antioxidant and growing and regeneration, so you'll have degeneration, right? And you start having all the degenerative problems, and it will aggravate the whole thing, right? Because you don't have antioxidant and you have too much of pro-oxidant. Okay, so, and this free radicals will stimulate the aromatase and convert all your 6-hormone to estrogens, right? And then estrogens will stimulate more of the steal and conversion of the cortisol of the cholesterol into cortisone. Estrone is a culprit, by the way. It's and estrone works like insulin. Estrone is inflammatory and proliferative, same like insulin when it's high. It's inflammatory and proliferative. Bad guys, those estrone. That's very important to keep the ratio between estrone and estradiol less than 1. Okay, so very important, all your patients, measure the estrone and the estradiol ratio. Measure the HOMA IR, which is the formula we talked about. Everybody, can you do that? Can you promise me, everybody here next Monday, you have your HOMA IR, you have your ratio of the estradiol, estrone to estradiol, you have your testosterone level, you have your progesterone level. I need the 6-hormone level as well with it. I need a complete metabolic panel, including those basic hormones that we talked about. And leptin adenobunectin ratio, it's very important. So measure that as well. Okay, so the range has to be what? Less than 1, above 3, you are in a problem. You will have high risk of having cardiovascular diseases, stroke, all the problems, and you become liable because you're telling your patient you have nothing and they have problems. In the future, if you don't really tell your patient you have a problem and the patient is out from your clinic thinking he's healthy and he has a problem, it's a liable for the doctor. This is the future, not now, because now we don't know. But the future, it's going to happen. Okay. So a chronic insulin elevation leads to activation, as we know, NADH, and it compromises the mitochondria and leaks the free radicals. Those free radicals leads to oxidation of glucose and leads to glycans, and hemoglobin A1C will be high, and you have a lot of those glycans, which is free radical generator causing more damage to your blood vessels. It leads to accumulation of sorbitol, especially in your cornea or in your lens, which leads to opacity and cataract. Eventually, you end up with you need cataract surgery, right? And it activates the protein kinase, which leads to further free radical generation and damage on the endothelium. Very importantly, it stimulates the xanthine oxidase activation, and uric acid can go a little bit high, and you diagnose the patient has gout, and you start giving him allopurinol. And the reality, he could have snips of gout, by the way. It's not necessary that he may have snips of gout that's being triggered by insulin resistance. And so instead of giving him allopurinol, work on his insulin. Say, you may not have full-blown gout. You may have a snip of gout that's being triggered by your insulin resistance. So why have to give them allopurinol? Why we don't work on the root cause instead of working on the consequence? To be more smarter doctors here, right? Okay. Result, endothelial dysfunction, inflammation, mitochondrial failure, aging, risk of having cancer, dying from stroke, heart attack, and contributing how much population are dying per year? 2 million people. All right, so I think we went through all of this. And when you have too much of free radicals, you impair your glutathione, you end up with using all your NAD or your glutathione, and you end up with this vicious circle of oxidation, oxidizing the glucose, the protein, the lipid, and damaging, rusting. It's like rusting. What's oxidation? Why we age? We rust. Why the car age? Rust. Rusting is the problem, right? And we need to stop that rusting. How we can stop the rusting? Start with managing the insulin resistance. Of course, then you have the inflammation, the blood vessels, and these macrophages, when they get activated, they release interleukin-6, transforming growth factor beta, and your blood vessels, the atherosclerosis, is not just flat plaques of fat, oxidized fat. No, it's also fibrosis. It's also calcium. So you have calcium, clot, you have fat, and you have fibrosis. So when you manage this blood vessels, say, oh, I'm just going to give them statin. Okay, so statin, what does? Okay, it will deplete your cholesterol. Okay, but the problem is not the cholesterol, it's the oxidized cholesterol. You may have normal cholesterol, but you have oxidized cholesterol, so it's not going to help. Okay. So what exactly you need? Not statin. What you need? You need cyclodextrin to pick up all this oxidized fat, right? Okay. What other thing you need? You need to detox the calcium deposits. So you need EDTA. Okay. So cyclodextrin, EDTA. What else? You need losartan to break down the fibrosis. And you need some aspirin, low dose, to break down the clot, the plaques, the platelets deposition, right? Those little clots that's happening. In order to clear this blood vessels, those are things, okay? I give statin if patient has familial hypercholesterolemia. I will justify giving that, but I can do better with cyclodextrin, detoxing, normalizing all the free radical generators, improving the liver function, giving cholestyramine is a good thing too, versus giving statin. Okay. So what will happen when you have too much of fatty liver? Your liver enzyme goes up, especially the gamma glutamyl transferase. When you see it as high, oh, this patient may be, drinking alcohol or has problem in his liver. No, it's insulin resistant, right? Normal range is 10 to 40. If it's above 40, then there is a problem there. And the problem is because of insulin resistance, not because of the liver problem. It's the insulin resistance and oxidation leads to increase this enzyme. Okay, and what will happen to maybe those patients will have some anemia, inflammatory anemia. You see their, hemoglobin is a little bit low, and it's microcytic anemia. It's inflammatory because of all the iron is being deposited in his fat tissue, and it oxidizes into ferritin. And don't give them iron, please, because if you give them iron, they will turn more ferritin. The ferritin is inflammatory, will add more inflammation, more oxidative stress. So you need to manage inflammatory anemia by working on increasing the insulin resistance. Does that make sense? And so if you find that ferritin is high, then that's because of insulin resistance. Okay, it's a sign of inflammation. And where's the inflammation is the visceral fat. That's the visceral fat is accumulating all the iron, oxidizing it into ferritin, and lowering your blood serum iron. Sometimes it's going to be a little bit low, and they will have this hypochromic microcytic anemia. It's inflammatory anemia. Don't give them iron for those cases. And you maybe end up seeing them that they have low thyroxine. And you say, oh, I'm going to manage hypothyroidism, giving them thyroxine. No. If hypothyroidism is caused by inflammation and resistance, work on the inflammation. Work on the inflammation and look at the root cause. If it's insulin resistance, then you say, hey, your thyroid inflamed because of the insulin resistance. Let's work on insulin resistance. Okay? So now we know the root cause of all these problems. And we give you an analogy about those machines. They use it for the car, and they come up with codes of different parts. And yes, the mechanics of the car, they change those parts, and the parts are normal. They have no problems. The problem is another part that's causing those 3 parts to fail. Okay, we have that problem as well. Now, if you teach your AI about this lecture, then your AI will pick it up. So when you feed the AI with any clinical case, they will tell you, okay, all of this is caused by insulin resistance. Fix the insulin resistance. Don't bother giving them thyroxine. Don't bother working on his liver. Fix the insulin resistance. Don't bother. He doesn't have gout. It's because of insulin resistance. Okay. So we call it silent hemochromatosis spectrum because of accumulation iron in the fat tissue. And they will have iron overload catalyzed. Of course, this iron will oxidize, and those ferritin that accumulated is a free radical generator, will generate more inflammation and more damage in the mitochondria. So again, insulin resistance can lead to manifest as gout. Uric acid is high. Oh, patient has gout. Let me go ahead and give them allopurinol. Oh, no, fix the insulin resistant, his uric acid will go down. Why? Because the inflammation is caused by insulin resistance lead to activation of the xanthine oxidase, and that leads to the conversion into into uric acid. Okay. So we need to keep the uric acid less than 5. And if it's above 5.5, we consider it as metabolic toxic. Above 7 for male, right? Above 6 for female, but we want to keep it less than 5.5. Okay. And we know why, right? All this insulin resistance leads to activation of xanthine oxidase and leads to the increase. And so uric acid is not just gout, it's a mitochondrial poison at high level. And hyperinsulinemia drives oxidative stress through NOx activation. And this leads to mitochondrial increase in free radicals. And eventually, it leads to activation of xanthine oxidase for conversion of more purine into uric acid. It leads to depletion of your glutathione and more free radicals. It leads to toxicate the liver and increasing the liver enzyme. Your ferritin will be high. And all this is biochemical signature even long before the glucose become abnormal. And we start shooting in the dark, treating it in the wrong way, treating it as a gout, as a liver problem, as anemia, and the patient all he has is insulin resistance and insulinemia. Okay, so hyperinsulinemia leads to endothelial dysfunction. As you see, the blood vessels, how it's being narrowed. And we know the reason, because of the oxidized LDL, forming this macrophages will pick them up and forming this foamy flakes of oxidized fat that leads to stimulation of the release of interleukin-6, so stimulation of fibrosis, and then that's a good hot place or good environment for it's a good place for calcium to deposit. So you have calcium there, you have fibrosis, you have this fatty flakes, right? And this will lead to more accumulation of LDL, especially the oxidized LDL and the low density lipoprotein or small density lipoprotein. Those are the ones who can seep into the blood vessels and causing all this problem. And when you narrow the blood vessels, it will affect the kidneys. Kidneys think, oh, so they will absorb more calcium, so more sodium, and you end up with aggravating the hypertension. So endothelial dysfunction is the consequence of insulin resistance, and this leads to decrease in the nitric oxide and increase in the endothelin. The nitric oxide is a vasodilator, so if you decrease that, you end up with vasoconstriction, hypertension. You increase the endothelin, that leads to vasoconstriction, right? And so we need to normalize the insulin, because if you normalize the insulin, you will be activating the enos and generating the healthy amount of nitric oxide. But if you have too much of insulin, it's a sword with two edges, the insulin. Normal is good, high is bad, even low insulin is bad. So very important, it has to be kept at normal level and not constant high, and we don't even need it to be low. Because if you have low insulin, which is less than 0.8, I think, then you have a problem, because insulin stimulates the enos to generate nitric oxide. So we need to keep it at normal range, not high, not low, but normal, okay? So what will happen when you have insulin resistance? Insulin signal becomes selectively impaired. You have problem with generation of nitric oxide. You will reduce the enos activation, because if it's too high, it will lead to decreased activity of enos and generation of nitric oxide. If it's too low, also, it will compromise the production of nitric oxide. And then when you have too much of free radicals, what will happen? All this nitric oxide is being produced, they will react with it, become peroxynitrate, and peroxynitrate is more damning, more powerful free radical that causing more damage, okay? And eventually, this will lead to activation of the phosphokinase pathway, activates the release of endothelin, which leads to vasoconstriction, hypertension, vascular stiffness, and increase the platelet activation. And you end up with all the complication of stroke, angina, and gangrene, and all the complication that we know. So we need to reverse that. And how we reverse that is by managing the insulin sensitivity. Please start working on this. You'll be saving the lives of many, not just treating the diabetic patients with complication, not just weaning patients from insulin, but preventing patients who thought they are healthy. And from now on, you're all liable now, because now you know that the patients with normal glucose and hemoglobin A1C does not mean that he is not aging and his blood vessels are not accelerating into damaging and into a cardiovascular disease. We need to stop it from the beginning. And how we stop it, we show them this is the abnormal. And if you have this abnormal test, that's when your blood vessels are frying from the oxidative stress. And that means we need to work. Now, what's other stupidity that's being, I don't know, whether it's public or it's us, but there's patients taking insulin and then take sugar. Say, oh, I'm taking insulin so I can eat any sugar I want. Do you know what the insulin and sugar means together? It's mean gas and fire. That's what's mean. Means you're frying your blood vessels, frying it, because glucose is a free radical generator. Insulin is a free radical generator. You give them both, you are blowing up the blood vessels. So never ever recommend people to eat cake and then take shot of insulin. That's killing. And most of the death that goes by cardiovascular diseases and complication of metabolic syndrome is because of this bad habit. That needs to be stopped. The high sensitive C-reactive protein needs to be measured. Less than 1, we need it. If above 3, it's abnormal. Optimal could be less than 0.5, right? Above 1, we have endothelial inflammation. Above 2, we have high risk of cardiovascular disease. Above 3, it's a disaster. We need to measure that, which is the high sensitive C-reactive protein. It's different from the C-reactive protein. This is high sensitive C-reactive protein and has to be less than 1. And it's inflammatory markers, so it's indicating that, hey, your visceral fat is causing inflammation. When you have oxidative stress and free radical, that's why redox medicine is very important, because redox medicine explains everything for you. That's the reason what makes us unique as CDPM group here. We understood redox medicine. There is an academy for redox biology, by the way, in Utah, but it's not translated into clinical because they're a bunch of PhD and they don't want the clinician to be involved in their discovery. They want to keep it in research in animals. They want to be translating it to clinical, because I try to speak at their event and they say, you're not qualified enough for us, which is fine. Okay. It happens sometimes. But there is redox medicine. We are not taught, I don't think in medical school we learn about redox medicine, but redox medicine explains every pathology out there. Now, if you say why homocysteine is high, so simple. Insulin resistance leads to stimulation of NOx enzymes, generate free radicals, and the free radicals interfere with methylation. Okay, all the enzymes of methylation will be blocked by the inflammation and by the free radicals. So if you stop the methylation, what will happen? You will end up with high homocysteine. Okay, so with high homocysteine, well, one will think, oh, okay, let's go ahead and give them folic acid and B12. Fine, it does help, but you are not stopping the source or the root cause of pathology. You know, integrative doctors will say, you know, I'm treating the root cause of pathology. I'm patient with homocysteine. I'm giving them B12 and methyl B12 and methyl folic acid and managing root cause. No, that's not the root cause. Still, there's a root cause of the root cause, which is the insulin resistance that's causing free radicals. That's causing that compromise the methylation itself. And we need it to be less than 8. The goal is to keep it between 6 to 8. And if it's above 9, it's a problem. And homocysteine is a free radical generator. Same like glycans. They eat the blood vessels. And they cause damage in the endothelium. They are a free radical generator. And when you damage endothelium, you decrease the nitric oxide. You further, because nitric oxide is antioxidant, by the way. It reacts with the free radical, yes, become peroxynitrate, but then the hemoglobin will turn the peroxynitrate back to nitric oxide and water. If you have enough of glutathione, reduced glutathione, to reduce the hemoglobin's thiols, then the red blood cells will turn the peroxynitrate back to nitric oxide. So nitric oxide can be an antioxidant here with enough of a reduced glutathione, sulfur, hydrogen. And that's the reason why we need alpha lipoic acid and cysteine. Nitric oxide without cysteine is not good. Without glutathione, without sulfur hydrogen is not good. All the thiols. You need to give nitric oxide and thiols. That's the problem that we have. Some of doctors give nitric oxide. Yeah, give nitric oxide with thiols. If you give nitric oxide by itself, no. Because they turn to peroxynitrate, and peroxynitrate, who's going to convert it back to nitric oxide and water? You need reduced thiols. You need reduced glutathiones. Give them alpha lipoic acid. That's the reason when we are treating angina with nitroglycerin with time, yes, it causes vasodilation, was good, but with time, because of the narrowing of the blood vessels and the ischemia, you have free radicals, would convert the nitric oxide into peroxynitrate and leads to damage to the heart. With time, you will end up with resistance, more damage in the endothelium, then you need more of nitroglycerin. And so the nitric oxide is sword with two edges. It is vasodilator in the presence of enough of thiols. That's the reason I recommend adding to the nitroglycerin all the thiols. Thiols is what? Broccoli. Thiols is what? Alpha lipoic acid. Thiols is NAC. Thiol is cysteine and glutathiones. All of this needs to be part of your management if you want to enhance the production of nitric oxide and prevent nitric oxide from doing the bad thing. So if it's more than 12, oh, you're at risk of atherosclerotic. All right. So we think, oh, patient has homocysteine. Oh, he has SNPs of methylation. So let's just give them B12 and folic acid. And that's what they do. They may have SNPs. But really the root cause here is insulin resistant. See how much the insulin resistant manifests and all those conditions, and we're being fooled by thinking that we are treating the root cause, giving them methyl, and we think that it's all because of SNPs of methylation. But the reality is that could be there's a root for the root. And now we know it. Okay. All right. So nitric oxide, very important. You need nitric oxide and you need to monitor it. And we need to keep it at the range of 20 to 40. Less than, we need to keep it above 35. And we need to keep your urine metabolites of nitric oxide above 500, above 70, 500 to 750 above that. So you know that you have enough of nitric oxide. And less than that, it's a problem. Okay. And that's help you, to monitor your treatments, especially if you're giving patient nitric oxide. There's two options. You can do a endothelial function test. You remember the one that you put and squeeze the blood vessels. You put the probe infrared in the blood in the finger, and then you squeeze the blood vessels, and then with a cuff, and then open it up, and it refills. That refill leads to the heat to come out. And if your camera can detect the heat is coming out fast, that's mean your blood vessels are compliant. If it's slow, that's mean you have a problem. So you can do an endothelial function test, or you can collect the urine and you make sure that you have enough of nitric oxide in the urine, which is in the range of 570, 550. If it's less, you have a problem. Okay. But again, you may have low nitric oxide metabolites because of the insulin resistance and the free radicals, because those free radicals takes the nitric oxide, turns it to peroxynitrates, and reduce the level of the nitric oxide. And eventually it will lead to hypertension, and it leads to sleep apnea and all the problems of free radical or oxidative stress in general. Okay. In addition to insulin problems that we know, we need to measure the ApoB and ApoA ratio. ApoB is a bad fat, and that needs to be less than 0.6. If it's more than 8, then you have risk of atherogenics. So we need everybody to measure the ApoB and ApoA. Those are bad fat versus good fat, and it has to be less than 0.6. Above 8 is not good. That's mean you have high risk of cardiovascular disease. That's mean you have insulin resistance, you have endothelial dysfunction, and you need to normalize it. ADMA, also dimethyl arginine, needs to be normalized. If it's above 0.7 is not good. Oxidized LDL, this is very important. It needs to be less than 40. If it's above 60, you are in a problem, because this oxidized LDL are the one, and small density lipoproteins are the one who infiltrates the blood vessels and causing the atherosclerosis. So measure all of that when you come next Monday, and let's find out the correlation between insulin resistance with all those labs. So insulin resistance leads to activation of this PI3K, AKT, and leads to decrease in the nitric oxide. It leads to increase in the endothelin-1, which is a vasoconstrictor, leads to increase the vasoconstrictor endothelin and decrease the nitric oxide, which leads to hypertension, right? And that's part of the components of metabolic syndrome. Now we know insulin resistance is the reason why somebody has hypertension. Okay. And Somebody has hypertension, say, oh, I'm hypertensive, but I'm not diabetic. Yeah, you're not diabetic based on what criteria? Oh, based on hemoglobin A1C is normal and my glucose is normal. Did you measure your insulin? Could be that the insulin led to your hypertension. Your insulin resistance led to your hypertension. Most of the time you will find that's the reason. Okay, so fix the insulin resistance. And you may fix the hypertension where the patient does not need any more hypertensive medication. Make sure the C-reactive protein is less than 1. If it's more, it's a problem. If it's homocysteine, make sure it's less than 9. If it's above 9, it's a problem. And make sure that your nitric oxide metabolites is above 40, less than 20, you have a problem or deficiency. And, optional high ApoB, ApoA ratio and high ADMA, high oxidized LDL, all of these are indicator of endothelial dysfunction, is indicator of insulin resistance. And you can fix all those abnormal lab just by fixing the insulin sensitivity. So again, hence hyperinsulinemia contribute to atherosclerosis, contribute to when you have narrowing in the blood vessels in the kidney, you will end up automatically increasing the renin and increasing the sodium retention. You'll end up with left ventricular hypertrophy. You end up with angina, ischemia. And we need to look at all this lab. And those lab, you can normalize it, not by giving statin, by improving the insulin sensitivity, especially those lipid profile that you can see here. ApoB has to be less than 90, high risk above 90. Low density lipoprotein, which is the bad one, you need to normalize it, right? Has to be less than 900. And above 1,200, you have a problem. Those low density lipoprotein, they deposit into your blood vessels and they're causing the plaques. Make sure you measure the triglyceride HDL ratio. You need to be optimized, right? Less than 2. If it's above 3, you having a problem. And all of this lipid profile lab can be normalized by improving the insulin resistance. Now, we still have more 15 minutes and then we can do the questions. I will do 15 minutes and then we move on to the questions and we can finish in next Monday. I will be releasing this book. There's a book I created for it. The title of the book is The Metabolic Codex, and it shows how hyperinsulinemia create the metabolic syndrome. So the metabolic syndrome, who creates it? Insulinemia or insulin resistant. And we now understand the metabolic syndrome is hypertension, dyslipidemia, obesity, right? And insulin resistant and hypertension. So we know the components here, and all of this is created by insulin resistance. And if we fix insulin resistance, we fix the metabolic syndrome. Now, what is the disaster of hyperinsulinemia? People wondering why cancer is increasing. Why cancer rate is increasing? Well, you can attribute cancer increase to many things. You can say EMF, toxins, our food, you can blame it to many. And yes, they're all contributing and adding up as a factor to compromise your immune system and stimulate the growth of those cancer to evade the immune system. But one issue that can be fixed is the insulin resistance. Insulin resistance, insulinemia. Insulin is anabolic, like Dr. Stefan said. And he said, man, you are against insulin. I don't like anybody against anabolic because I want to make my muscle all the time big. And I told him, yes, anabolic, all the anabolics are good if you give it in the right way. If you give it after you inhibit the mTOR and you stimulate the autophagy and you get rid from the weeds, which is inflammasome, senescent cells, cancer cells. You can do it with fasting 16 hours. or you can do it with mTOR, or you can do it with low carb. All of this would help, right? And then you go ahead and you give your anabolics. But if you give anabolics without fasting and without inhibition of the cycle of inhibition of mTOR, you may cause cancer. Insulinemia, any growth peptide or any anabolics that's high constantly, not spikes. Spikes is good. We need spike. Goes up and down, that's fine. But high and constant generate pathological free radicals. Again, free radicals are good if it's physiological and it's spiky, but it's bad when it's high and constant. Insulin high and constant means free radicals, pathological, high, constant. And then you have the growth. Growth and free radical, pathological free radicals, means mutation, means cancer. So one of the reasons why all this cancer is happening is because of insulin resistance. That's the conclusion of today. Because insulin stimulates mTOR, insulin causes increase in insulin growth factor 1, which is tumor proliferation. And when you do that, you inhibit the autophagy, which can be, we can stimulate autophagy by inhibition of mTOR and fasting a low-carb diet, and by reducing the insulin. Because if you have insulin all the time, those cells will start, and what other things that they do in addition to stimulation of the tumor and to growth, they compromise the immune system. This is the problem. They shift the immune system from Th1 cytotoxic T cells to Th17 and Th2. And when you shift that, you don't have enough cytotoxic T cells. That's what's happening to a patient with insulinemia. You remember a patient with insulinemia, they say sometimes I feel like itchy and I'm scratching. I don't know why. Because that shift to Th2 generates histamine. Mast cell activation syndrome is a bad thing. It leads to cancer, right? COVID, spike protein. They inhibit the ACE2 and they activate angiotensin type 1, which is the pro-inflammation, and especially the Th17 and Th2. All of this compromisation of the immune system leads to compromising immune surveillance against cancer, and leads the cancer to be popping up, right? In addition to that, if you have constant high insulin, then it's not good because you're growing the blood vessels of the cancer, right? And with the free radicals, you're damaging, you're causing mutation, causing more cancer. Now, patient with gangrene, and they are giving them insulin, and the doctor endocrinologist say, well, insulin is good because it stimulates the growth of the blood vessels. That's what I need in my patient with diabetic foot. I need blood vessels to grow. This is what I hear from endocrinologists, by the way. Yeah, but he doesn't think that those blood vessels that you're growing are bad blood vessels, are very fragile, damaged because of what insulin does in stimulating the NOx and compromise the mitochondria. So you have bad blood vessels there in your foot. Very fragile. And yes, those diabetic patients, their blood vessels are very fragile. Even if you're trying to put catheter, it's just you easily break them, by the way. Okay. And what would happen when you stimulate the blood vessels in the eye for patient with diabetes? Proliferation of the blood vessels and they blow up, and you end up with hemorrhage, and they will lose their sight. This is exactly what happened to a patient with diabetic type 2 who's on insulin. They have gangrene, they have retinopathy, proliferative diabetic retinopathy, blowing up their blood vessels in their eye and hemorrhage, and they cannot see, and they lose their sight. And then this is one of my relatives, which I wean him down from 70 to around 6. And if we add him GLP-1, he doesn't need any more insulin. And if we add 6 hormone, it's done. Right, because I did it with diet and because that's what's available overseas. They don't have, the luxury that we have here. We have more tools than overseas, but we need more intelligent doctors like you to rectify the path of managing your patients. So now we know why we have cancer. Part of it is easy to fix, which is insulin resistance. Again, environmental toxins are part of it, yes. The EMFs, like Dr. Yusuf is saying, yes, all of that. But this is something we can fix. This is a career for every integrative doctors to go after those patients with diabetes and fix them and save their life from dying. Okay. So what would happen if you have high insulin? You have high IGF-1, you have high stimulation of mTOR, you have activation of the you have suppression of P53, you have compromising the immune surveillance, you're shifting the immune system away from cytotoxic T cells and Th1, you're compromising your natural killer cells, right? And the cancer predictive lab, you may find within normal range. But again, this is the reason why we're having this cancer. And when you have cancer and you have insulin, hyperinsulinemia, the cancer gets worse. So part of management of cancer is to wean patients from insulin. Now, there's a management of cancer giving them insulin, but that insulin is just a spike. That's fine, just to starve the cancer. It's different from constant high. Okay? And so you need to keep the IGF-1 at normal range, 100 to 300. High is going to be risk of having cancer. Fasting insulin, you need to keep it less than, as we said, less than 3, range of 3 to 6, right? High risk for cancer, if it's above 10, you're having a high risk there. C-peptide needs to be at the range of 0.8 to 3, and if it's above 3, you're having a problem. Now, C-peptide is very important to be measured when you are weaning patients from insulin, because you don't want to wean the patient insulin enough, too much where your C-peptide is less than 0.8. That's not good. We say hypoinsulinemia is as bad as hyperinsulinemia. Okay? So when you wean your insulin from the patient, measure the C-peptide and make sure you're not going below 0.8. Because C-peptide is indication of what? Of endogenous insulin, and you want to make sure that you have enough of endogenous insulin, because if it's less, and then make sure that when you wean the patient with insulin, you make sure the glucose is okay. Yes, that's good for monitoring, and you need to normalize and give GLP-1 and other things to compensate, and metformin to compensate for the weaning of insulin. You just don't just take the insulin out. That's a disaster. Okay, so the other thing is that we know the insulin leads to shifting of the immune system away from the cytotoxic T cells and Th1, because it increases interleukin-6, as we know, those fatty liver or fatty liver and fatty visceral fats, they release a lot of interleukin-6, which leads to activation of the Th17 and Th2. And this will compromise and decrease the cytotoxic T cells and decrease interferon gamma and compromise the immune surveillance, which will put the patient at risk of cancer progression. Also, you know, the Th1 and cytotoxic T cells are important to clear the body from viruses. That's why people with insulin resistance, they're all the time having flu problems, right? They have viral problems, and the reason because their immune system is being compromised. And then you add the COVID-19. Well, if you have too much of insulin resistance, your body is trying to compensate, so they express too much of ACE2. ACE2 as a vasodilation to compensate for the vasoconstriction caused by the insulin resistance. So they have a lot of receptors for the spike, for the virus. That's why they are more prone to be infected and with the virus. And then the spike protein, when it's being inhibited, the ACE2, what will happen? That will shift the immune system away from cytotoxic T cells, because the angiotensin, the renin-angiotensin type 1, it's going to be overactive, and that leads to activation of Th17. So the COVID compromised the insulin resistance, and insulin resistance put that risk of patient of COVID, and it compromised the post-COVID-19 syndrome. So they are all overlapping. You know, those post-COVID-19, mast cell activation syndrome, insulin resistance, cortisone dominancy, they all overlap here, okay? And now we understand the concept of shifting of the immune system. It's by insulin. Estrone does the same thing, estrogen dominancy. Estrone shift the immune system away from Th1. And cortisone. Cortisone also shift the immune system away from Th1. All of this compromise your Th1 cytotoxic T cells and all the cytokines that relate to. That's why we ask the patients to do lymphocyte mapping cytokine profile, so I can know their immune status. are protected against cancer or not? If they have high interleukin-4, interleukin-2, and they have high Th17 and high Th2 and less of cytotoxic T cells and lymphocyte and Th1, this patient has a high risk of infection and cancer. So part of your management is to do lymphocyte mapping, cytokine profile, which is one of the pillars of chronic disease prevention management, is to balance the immune system. Okay, so we talked about all of this. The CRP has to be normalized. Ferritin has to be normalized, and ferritin increase is due to insulin resistance. So people, they mistaken, they say, oh, patient has homochromocytosis. No, the patient has insulin resistance, leads to inflammation, the visceral fat, leads to accumulation and oxidation of the iron in the fat into ferritin. So that's why the ferritin is high. And all this iron is being converted into ferritin. So we need to normalize all of that, but just by managing the insulin resistance. Again, the insulin leads to accelerate the biological aging. How does that? Because of stimulation of NOx, generating free radicals, compromising the mitochondria, which leads to damage of the DNA, shortening the telomeres because of oxidative stress, increasing all this inflammatory cytokines, leads to increase the inflammaging, which is interleukin-6, and it compromised the mitochondrial biogenesis because of decreased the nitric oxide, and it decreased the NAD, right? And it decreased the sertraline activities, and all of this is because of insulin. So patients with insulin resistance, they age fast. So you are a doctor and you call yourself an anti-aging doctor and you want to slow the process of aging, the first thing you do is to look if the patient has insulinemia and insulin resistance. I think we're good tonight. I don't want to be stressing you more than this. We want to have our platform to be more both sides, but I think you got the message here very well. And as doctors, once you get the concept, the logarithm, you will thrive more, and we will be learning from you. So I'm expecting you coming here, adding more to this, this basics based on your clinical data that's coming from your patients. So can we promise me next Monday, because I want to put more clinical cases forward, plus we're going to do some genetic SNPs and understanding the importance of genetic testing for personalized medicine, but I need all your inputs here. Plus, I need you to invite as much as doctors to attend this meeting, because 20 doctors will not do much. We need to have at least 100 doctors to make a change in this field and save 2 million people dying every year. So if anybody has questions.
Yeah, Dr. Halasa, thank you. I have a question regarding a recent trend I've seen, especially young men going into ketogenic diet or carnivore diet and still managing to either maintain their insulin resistance body type or worsening even on just a carnivore alone. So I guess even in that situation, if you overdo protein intake, that eventually also leads to conversion to glucose and then increase the insulin with the same problem. And then they also end up with all these anabolic hormones for muscle growth and testosterone and all these things. So it's just like what you said, like it's a contradiction to do those hormones in the setting of insulin resistance, and it can be a dangerous pattern. So I don't know what your thoughts are.
Yes, definitely. I will not start giving growth factors. And patient has insulin resistance and has inflammation. If you want to do it, you have to do this mTOR inhibition cycle, whether you're giving mTOR inhibitors, rapamycin, or you do fasting or low carb. And by activation, the autophagy, you get rid from all the senescent cells and cancer cells and inflammasomes, then that would and you lower your sugar and you improve your insulin resistance, then it's okay for you to go ahead and give them the growth factor. Now, in terms of giving them a lot of meat and proteins, you don't want to also overload the liver because, you're putting pressure over liver, and the liver is sick from the insulin resistance already because of the fatty liver. So you need to be, the intake has to be, of food has to be balanced. Low carb, but not, eating protein and like, like, when you give the GLP-1, first of all, the craving, it will decrease, so they don't eat a lot of meat, by the way. If you have too much of leptin, and that's the reason of craving, and that's the reason they eat a lot, then that's the problem that needs to be fixed. And the fix for high leptin is GLP-1. GLP-1 is a miracle. But again, you need to make sure when you give GLP-1, you give things that helps to increase the gastric empty, and you make sure you give them enough of multivitamins because they have nutritional malabsorption. Plus, you make sure you clear the body from all the fat-soluble toxins released from the shrinking of the fat. If you do that, you're on the safe side. So you need to be smart when you recommend those patients. And based on the data, you just send me the data of the patient, because my AI is now smarter than me. I'll give it to my AI and I come up with a personal management and treatment. But once you adapt all those protocols and those lectures, and you start involving, engaging, and bringing your presentation, while you're putting your presentation through your AIs, then your AI will become smarter, and even smarter than my AI. So we may end up learning more from you as a human intelligence, as a doctor, plus whatever processing of your AI is doing and adding more to the table. Does that make sense?
Yes, thank
Okay.
you.
What was the,
Can I add something here? Sorry.
Yes.
So in the clinical setting, thank you, Dr. Halasa, great talk. But if you please can upload it because I didn't start early. I'm
Yes,
sorry,
there's
I missed
one
the first
previous
one.
one, and I will upload this one too.
Yeah, I saw the last previous one. Thank you. But honestly, once you start balancing them, I mean, you can still put them on a carnivore diet, balance I never do a pure carnivore. I usually balance it with, some vegetables. But putting the GLP-1s or GLP-3s, actually, at this point, I don't believe people should be using GLP-1s at a, balanced dose with balancing the hormones, balancing your HGH, balancing is key. And it does not spike their insulin. I find that they end up having monitoring their blood sugar. They improve. It's just all about the balance and adding the GLPs because it reduces the inflammation. With all your other antioxidants and all the ALAs and all that kind of stuff, they don't have a problem. You can still add your HGH peptides or, improve your other hormones without having a problem. And I see that in clinical. And I think I would love to have, maybe let's have clinical, let's have a clinical setup where we would say we're all participating with our patients. Let's have parameters and let's all input data, and then have your AI just, kind of, maybe we can publish something out of it. But I think we all should enter, live data from patients. And it's all about the balance. And I have no problem. People came with 12 insulin and all that kind of stuff, or even 22, and they all went down. But it's all about balancing them. And GLPs are amazing, honestly, reducing the inflammation, reducing the problem that we're seeing with hyperinsulinemia.
I want to respond to this one, if that's okay.
Yeah.
Yeah, and I think the thing is I said it last week, is context. What I'm imagining is at what stage are we seeing the patient in? Is this a patient that is on a lot of insulin, and the GLP is sort of the bridge to help to wean them off, because you cannot just stop anything cold turkey. And yes, there is other things that can be doing in the background that are creating what I call now a better terrain that is contributing to improving metabolic processes. And what I'm hearing too, Dr. Halasa, is a paradigm shift, because it's the same processes, same mechanisms, but a focus on something that you wouldn't necessarily, well, that I certainly didn't necessarily think to tie into everything, and that's having a normal hemoglobin A1C, and then, oh, I'm not diabetic, but yet the insulin typically isn't checked. Probably should be. Well, I know it should be, so that you can know that there's insulin resistance and that insulin is having all of these effects, overgrowth and bad growth, like you said. And I just want to make myself clear, either for next week or the week after. Like I said, I'm in the process of completing a presentation that I never. I mean, it's another paradigm shift, but it's like a parallel shift, really, and it's not to distract from the insulin model whatsoever. This is more for, maybe you have a patient that's further down the line, and you're trying to optimize certain things that you cannot optimize right away with a person who's on, who knows, 100 units of insulin every day or something, and trying to get them from here to there. But for the long term, um, which is sort of the personal medicine side, where somebody wants a total guidance, and they're willing to pay for that expert advice. That's why I was really excited about this acid model, which is really one and the same. Um, it just sees it's a measurement of pH every day that I'm working on seeing if, how it correlates, and that whether it's free radicals or it's acid is easier to measure on a regular basis. Acid may be contributing or is a part of, or I don't know which one is more or less, this catalyst for transformation. Um, and as it applies to the meat, regardless of what kind of diet you do, the things that are hard to see are what kind of meat, and what's the quality and how contaminated and all that stuff. And so it's hard to know, how is the quality of the meat without being able to test the meat. You can test the pH urine to see if maybe this is unfavorable meat because it's making my terrain more acidic. It doesn't have to. When I talk about alkaline diet, it actually is not a diet. It's making sure, however you approach optimizing, that the diet is creating a more or less, or contributing to improving the pH, especially if the pH is super acidic, and especially if somebody is decompromised, or they're compromised, and they are, what I call, the terrain is collapsing, meaning that their membranes are damaged to the point where they're leaking, like leaky gut, leaky cells, leaky brain, leaky mitochondria. And so what I see is a parallel story here, that at least it can be monitored by the patient. Now, this isn't to say this is to go along with this specific thing. This is more just additional insight to say, well, how do we know about this? How do we know about that? If somebody is really compromised, that's when the focus becomes on what are the different angles that we can affect the overall acid terrain to pull it to a more alkaline state, because when it's in an alkaline state, the acid will not serve as the catalyst for change and conformation of the cell. And that could also involve the change in the sensitivity of the insulin receptor simultaneously, as free radicals are a part of this too. Free radicals are, kind of represent electrons, and acid represents protons. Which one is the actual catalyst, like a catalytic converter or a transformer in a car? I don't know. but I tell you that this brings a spice, not to get in the way or change this model, but to add additional insights such that you kind of know where you're going. What do you do after that? You don't want to be on the GLP forever, right? So that was my point.
Yeah, I don't think once you get into GLP to reduce your fat or visceral fat, and reduce your weight to normal and increase your muscles and increase insulin receptors numbers, you don't need that much of GLP-1s. You will be weaning from GLP-1 once your body is being in shape. With muscle bulk is increased, insulin receptors increase, you will be weaning from GLP-1. But it's GLP-1 will be part of the management because it does increase the leptin sensitivity, so it will prevent the craving of more food, and that's part of the problem with managing patients with insulin resistance is that they cannot stop eating, and they eat all kind of junk and they crave sugar. So once you increase leptin sensitivity, once you increase insulin sensitivity by GLP-1 or GLP-3, there's types of different type of GLPs. One has less toxic than other. But again, we can even make the GLP-1 less toxic by loading it cyclodextrin. Now, I mean, let's come up with something here very important, which is diabetic mellitus. There's 3 types of diabetic mellitus: type 1, 2, and 3. 3, they call it the brain diabetes, where you have brain insensitivity and things like that. But let's come up with a type for this. And we can say diabetic type 0. What's diabetic type 0 means? Means you have insulin resistant, high insulin, and you homeostatic assessment model of insulin resistance is above 3 or above 1, because we need to be less than 1. And we can call this condition as diabetic type 0. And it needs to be managed. And we come up with a code, and it's a disease because you have high insulin that's causing damaging in your blood vessels. You can have 10 years and 15 years of high insulin without manifestation of high glucose or hemoglobin A1C. They will be normal. And we call this diabetic type 0, right? And we can start having publications on it, and it become a medical terminology, and it has a protocol of treatments, and we have very clear diagnosis, because what you will call a patient has insulin resistance, and it's not diabetic type 2. Okay,
They're calling it, sorry, Dr. Halasa, but isn't that the pre-diabetes that everybody goes to hell with? And then they don't see the patient for a year. That's what they call it,
Well,
pre-diabetes.
pre-diabetes, still they have hemoglobin A1C between 5.6 and 6.7, something like that. No, that's still before pre-diabetic. Before, I'm talking about hemoglobin and A1C less than 5.6, glucose less than 100, the fasting glucose. Okay?
I like it.
Still, they have insulin resistance because if you do the calculation, you will end up with the insulin resistant. The HOMA will become a little bit above 1.
I like it. I like it because
We can call it
we-
diabetic
we
type
need-
0. And that will be a disease that needs to be prevented and managed, because we cannot just leave it like this without having a label, a recognized condition, and it's a critical problem because we know any abnormal increase of insulin can drive the cancer and trigger cancer, can drive all these problems that we have, and we can stop it. But if we don't put the label on it and define it as a problem, it will be overlooked by the medical community, and nobody will take it seriously.
I like it. I like that because it fits with the existing language and it's appropriate. It makes sense. It's type 0. It's instead of trying to describe it, well, it's insulin when it's high and but your sugar is low. That's not a name. And and this needs a name, a language to go with it. It's a paradigm shift. So I'm 100% in alignment with that. And
Do you agree, everybody here, besides Dr. Joseph? I will agree everything what he say. He agrees everything as they say. I need people who will disagree with us, so we can.
Well, keep in mind,
review.
I'm looking for the places where we connect,
Right.
not looking to counteract or disprove unless there's something that you didn't see that I can, like me talking about the acid is something, you know what? You don't see it, and I know most people don't see it because that was a paradigm shift for me, and I don't want to I don't want to confuse this what we're doing, but when I do the lecture, it's going to be like it's going to be like, oh wow. But I'm looking for the places where things line up because it does make sense to me what you're saying.
Hey, Dr.
Right.
Salasa, I started off in diabetes for some reason in medical school. I was in the honors program. I got a master's thesis in diabetes, and we were using. No one uses embryonic stem cells, but we got a bunch of pigs diabetic with streptozotocin, killed their beta cells, and then we took embryonic insulin producing tissue from 12-day-old rats, and we got these Wistar rats diabetic. We took the embryonic tissue and they have a 21-day gestational age, but at day 12, the pancreatic tissue is just mature enough to make insulin. And it's not so mature that it creates a reaction. And we transplanted that under the kidney capsule of these Wistar rats that we'd made diabetic. And within a month, their serum glucose was normal. And then the dean called me in and said, cut that out. And he was right. That was embryonic stem cells. I didn't understand at the time. But what we did learn is that real live diabetics, that streptozotocin killed the beta cells. So there was no insulin. And what they had was hyperglucagonemia. Their natural glucagon did not have its inhibition by the insulin. That's a yin and yang. These glucagon-like proteins are basically, I don't actually understand it because I'm not in that area anymore where we did the assays. But the glucagon, natural glucagon level in these folks with type 1 diabetes is very elevated. And glucagon drives sugar up. And the lack of insulin also exacerbates elevated glucose. I'm wondering, and then these delta cells make somatostatin, which is supposed to try to improve the conversation, those islet cells. At some point, if we're going to use GLP-1s and GLP-3, somebody ought to look at the native glucagon and the native insulin. It's not hard because these are big molecules. That's why insulin was one of the first proteins that was isolated because it's so darn big and easy to use. There's your paper. I mean, that would be, there's something going on in the islet cell, a conversation. And it gets back to first principle thinking. You were talking about hydrogen ions and so forth and acidity. It's electricity, electrons. And let's kind of focus on energy is healing, as Dr. Tennant put it, voltage is healing. Actually, he meant amperage. Voltage is just potential energy. But let's look at what is happening in hyperinsulinemia to the mitochondria energy-wise. We talked about it, kind of skated around. That's the first principle. How do we get electrons in the body? And the more electrons you get in there, the less food you have to eat. If you think about the sun, it's a cathode ray tube. It's like creating an X-ray, and the Earth is an anode. And in photoelectric effect, the sun hits the Earth, it reflects all these electrons. You walk barefooted, it gets in you. You could get to eat less food. So the answer is going to be something not Tesla-like, non-physical, vibrational energy into certain areas, mitochondria, the infrared, it's complex 1 in the mitochondria. Methylene blue helps to skip over the second and third and give them a rest in the electron transport chain. All this stuff is electron and energy. And let's not lose sight of that as our first principle, in the fact that what we're looking at is kind of far away from that. But that if we're going to talk about insulin, native insulin, that we need to talk about glucagon and native glucagon, not this GLP-1 and 3 and so forth. What a great lecture. So that was really good.
Yeah, David, let me comment too, on what you said. And that's where I think it's important for us to, sort of have it organized in our mind, what level, are we working at, and what level is appropriate for this particular patient right now. He's on 100 units of insulin a day, and we need to get him from here to there. Now we know he's too decompensated to just do it with red light alone. Because that's the way, just in general, when you're in the practical sense, given, okay, if in a perfect world, let's assume GLP is perfect, no risk whatsoever, that would make a nice bridge to help get them over. They could still do the red light, for example. That's just one way of getting electrons and actually structuring the water to return the terrain. Now I'll go into this in my lecture once I have everything together and I have the right language, so that this will make sense of structured water in the body. It will make sense of the lectures that we had on damage to the cell wall receptor dysfunction. It will make sense of that. And yes, I want to comment. Part of the returning the terrain back from a collapsed state involves light energy and but multiple things. Everything that you're doing basically is contributing to that, which is basically returning you back to where you came from, which is the natural way of living. But everything will make sense, and so we won't have scattered individual therapies thinking in terms of, now this isn't what you're saying, David, but this is, I know what I fell into. Okay, maybe I should try this. Maybe I should try that. Maybe I should try the Nanovi. Maybe I should try the red light. Maybe I should try methylene blue plus the red light. And because I was missing a few key concepts, many of them that have been buried, as it always seems to be the case, once I was able to grab a concept I never realized, kind of like Dr. Halasa, you didn't see this one. I didn't see this one either. This is a parallel paradigm shift. Suddenly, everything started to snap together. Like now I could see how it's not just this, it's not just that, but I could actually see how they were crucial for this changing the terrain on the inside of the body that, like you said, David, that causes the body to spontaneously, or that's what you were kind of referring to. You're giving the electrons, you're giving the components that allow the body to, just like alchemy, make the transformation that it does naturally. In this context, I imagine the patient, you know, to try to get somebody to do this, change their diet, do this, do that, and get off of 100 units, it would take, that would be a rare patient who says, I am absolutely determined. I don't want any other meds. I want to get off. Then we're going to have a protocol, so to speak, that embodies the different ways that that we will transform those insulin receptors back into their receptive state, and that person has to be committed to doing these things daily. The diet has to be, overcompensating diet. It's like the elimination that you have to get rid of all the things and be extreme for a while in order to get there. But most patients aren't going to do that. That's a rare patient. So having something that fits the average patient, how do we get from here to there? And it makes perfect sense to me, especially the hunger.
Let me add to that. Okay, so basically, once, because I have patients and I did shift them from 70 international unit of insulin to 6, and only by diet and by antioxidants and by metformin. Okay, that's it. If they have the tool of sex hormone and GLP-1s and detox and all the things that we have, psychodextrin and all that stuff, they will completely eliminate the insulin from their equation. And those patients they lived a complication of diabetes. I'm talking about gangrene with amputation, and he lost one of his eye because of diabetic retinopathy, and that's because of insulin induced, by the way. So it's not hard because we have the tools here for those patients. Once you give them GLP-1 injections, and once you make sure you give them nutrition and psychodextrin, you don't just give GLP-1 like the mainstream medicine is doing, where they get nauseated and vomiting and they don't take it and they don't respond very well. You need to do the whole protocols of screening all the free radical generators, giving them metformin, giving them berberine, giving them all the nutrition and alpha lipoic acid, giving them the GLP-1, and looking for the genetic SNPs if there's any, because if you have some leptin genetic SNPs where they are all the time hungry because they don't have the leptin is resistant due to genetic SNPs, then you need to come up with personalized medicine to increase the leptin sensitivity. Now, GLP-1 will increase leptin sensitivity, but some of them, they may be having resistance even with GLP-1, and there are SNPs there. And so then you need to come up with how I can overcome that, what kind of nutrition needs to be done. Is there any nutrition to override those SNPs? So it is a work. It's not hard, but once they get optimized, and once they get all this insulin resistance out, and once they reduce their visceral fat, you're breaking the loop, the positive feedback cycle, and they will be maintained with their weight even after they wean themselves from GLP-1, especially if you give them supplement that support or increase the endogenous GLP-1s, and there are many out there as well. So it requires an intelligent nutritionist to really come up with a nutritional and lifestyle change and habit with exercise and all that stuff to maintain their weight and completely get rid from GLP. But if you just, like a mainstream medicine, giving them GLP-1 only, without giving them metformin, without giving them all this antioxidant, without normalizing their sex hormone, without detoxing their body, without looking for genetic SNPs. So once they stop the GLP-1, they may go ahead back and gain the whole weight and say, hey, I used the GLP-1, it worked in the beginning, and then once I stopped it, everything got back. The reason it got back because the management was not comprehensive.
Oh, absolutely. And just so that we're clear, I didn't mean to put it in a box and not include. I guess if what you're saying, what I'm saying is, I'm probably bringing some things to fill in some of the spots, and we don't always have a dietitian. The other thing is that not every patient is going to be the superstar that follows through as much as we think that they should. We know that that's just not the case. And in general, if it was only lifestyle change, if you just in the simplest terms, oh, you got to change this and change that. How often does that happen? What I like about this is it's something tangible and measurable to put your finger on and say, I can get you from here to here. I can get you from here to here. And because we are I'll just speak for myself. Because I've been top heavy in some of this, how do I get from here to here from other angles? Getting from there to over there has been a challenge because I was missing some understandings that I didn't have before. Is because is it this diet? Is it that diet? Is it, how important is this? How do you get over, is it structured water? Is it that? And what I'm trying to say is I found something. I found a missing potential. Well, I think it's probably one of the biggest pieces of the puzzle that will sort of answer, it will make it evident, more evident when you see it the way that I present it, and you won't know until you hear me present it. Once you see me present it, just like this, you'll see that this overlaps or fills in the gaps of how do you go further. You know, when you say eat a healthy diet and you don't have a dietitian, do you really know what diet to give or not? Probably not. You could revert to the
No,
ketogenic.
Dr. Joseph,
You could
you
revert to a
don't need,
ketogenic.
Dr. Joseph, once you train your AI about all the genetic SNPs and all your methods, you don't need a dietitian. You just throw the whole thing there and they will tell you exactly what kind of diet
I
you need.
agree. I absolutely
And better than a
100%.
dietitian, by the way.
Okay, I absolutely 100% guarantee. And if you add this other concept to it, you haven't heard it yet. It's
Yeah.
not put bicarbon water or any of that nonsense. Well, I mean that has its place. It's just a short-lived place. But when you, I'm saying I've got a concept that if you plug that into the equation with the other concepts, you'll get more. You'll get
Right.
more. I understand. You can only drive your AI as far as the questions that you know how to ask. I'm here to say there's a question that hasn't been asked
Right.
that I guarantee you 100% it will be a parallel, it will be a paradigm shift, just like the insulin, where suddenly it's like, oh, well, if I didn't ask that question or a question related to that angle and have that set of information or Dr. Joseph's slideshow and plug that in, that will, I'm guarantee you that will clear up ketogenic versus the Mediterranean diet versus how you see structured water, how you see infrared, how you it's the same thing. You plug in. How does how do these other tools that we have fit in nicely, because you have a big question that hasn't been asked, and if you don't ask it, I'm telling you, there's going to be a limitation. There's going to be a limitation because there's a basic alchemy that we're not seeing. That is the epiphany that I had, because it was there. It was there a long time ago, like a lot of the things. And I just didn't, I heard it in pieces and snips. You know, put it like this. This is what you hear. Oh, you can't have cancer doesn't grow in an alkaline environment or in a non-acidic environment. Okay, so do you check your pH? No. It's like somebody who learns a language and they learned one phrase. And I'm here to say, how can you act on it? And how can you act on it with essentially the same tools, but now you know. Now you know. You see what I mean? Now you know. You're not guessing. If it's that important that cancer can't grow in a non-acidic environment, then you better know what to do, other than try to sound smart. I'm not talking to you, Dr. Hala. I'm talking about the empty, catchy phrases that have become a part of my existence until I isolated myself, so I didn't have to listen to it, because the people who were telling me, not amongst us, but people in general. As my nurse in 2003 at one of the facilities said, Dr. Joseph, everybody's the doctor these days. Well, what I'm listening for is, okay, you said that the grand, pulled out the grand trump card. Now, how do you do it? And why?
Can you kind of give us a kind of a snippet of the question that you think we should be asking? Because I agree. If you don't ask the right question, you're going to get an answer to the wrong question.
It's just like insulin. You have to know how is an acidic terrain as measurable using urine as the measurement.
The
Blood doesn't make
problem I
sense.
have with Dr. Joseph about the urine acidity, right? It's not gonna reflect the tissue acidosis. That's the problem, because what we drink and what we eat, it goes to the stomach acidic, right? And then it's absorbed into the blood. Your blood pH and buffer system, there's two part of it, the bicarb in the blood, and then the other part is your kidney, will get rid from all the acid into the urine. And
You're
even if you,
you're right, but you're missing something. I'll
so
tell you
what
what
I'm
it is.
just
Go ahead.
saying is that if you drink a lemonade or something like that, your urine become acidic, does not mean that your tissue is acidic. What is the problem is that acidic tissue, especially the tumor microenvironment, when it's acidic, it actually aggravate the cancer, because the acidic microenvironment of the tumor does stimulate dedifferentiation of cancer cells into cancer stem cells. And also it shifts the immune system from Th1 to Th2 and Treg and make the tumor tolerance. That's the problem with tumor acidity. But we don't fix the tumor acidity by drinking milk or alkaline water.
No,
as
you're
they are.
missing. You're missing the
Let me
point.
just finish this one. You increase the alkaline of the tissue of the tumor microenvironment by giving alkaline food. Alkaline food are the polyphenols that activates the mitochondria, because as you said, acidic tissue means the mitochondria is compromised and leaky, and they are releasing hydrogens. No, normally they concentrate inside the mitochondria, but they release the hydrogen and they release the free radicals, by the way. And the hydrogen and acidity and the redox potential, they do. There is correlation between them. Most of the time, when you have oxidative stress, you have acidosis, by the way, because the mitochondria, when they leak the free radicals and the hydrogen. And now how I can decrease the acidosis of the tumor microenvironment is to give things that helps to activate the mitochondria and heal the mitochondria. And that's the polyphenols, the methylene blue, and this we call alkaline diet. Mistakenly by the public and some doctors, they think that if I drink anything that's alkaline, like alkaline water, or I drink anything that has a pH high above 7, like 8 or 9, that food will help to alkalize the tissue. That's not the case here. That's what I'm trying to explain. There is true, but the problem with urine acidosis does not reflect the tissue acidosis. Do we have any tool that measure tissue acidosis? We don't have it up to now. I don't. If you have something to tell me,
Yeah,
blood will not go above 7.35 to 7.45.
What's that?
The blood acidosis, a blood pH, your blood is so tight, it will maintain from 7.345 to 7. If you have pH acidosis or like insulin and all that, I mean, diabetes and all that stuff, that's a crisis. And I mean, that's going to change the electrolytes. Your blood is tightening up. So if you're talking about acidosis of the diabetic ketoacidosis, that's a different scenario.
I'm not talking about that. No, but
Right.
thank you. I'm glad you brought that up. That's why when I present it, when you see what I present, you'll see how that's there's multiple layers of misconception there. The ones that the doctors are, oh, it's just pH give, alkaline diet and baking soda. I'm here to say that the things that will, and when you, first of all, when you check the urine pH, it does fluctuate. What you're looking for is a morning pH, and you're looking for a trend and a sort of goal as a reflection of the metabolism. Okay, you're not looking at it as, oh, I'm acidic now, I got to take this. That's not, because I haven't given the lecture yet. This is a way to measure the metabolism in conjunction with the history and the full picture to move the patient. But the things that what you're trying to do is you're trying to repair the collapse of the terrain in true acidity in the tissues. What I understand what will happen is you'll start to have dysfunction of the the receptors, the sodium pumps, and I'll back this up with evidence literature to back this up, is that you start to have leaking or a reduction in the intracellular potassium and magnesium, and especially magnesium, which is rampant in right now. And what that means is that the terrain has the cells are starting to collapse. The receptors are not working properly. They're leaking the scaffolding, which is the minerals, are the like a scaffolding of a building. They are the thing that stabilizes the structure of the enzymatic processes, ATP, mitochondria. And if you have low magnesium and you can't get from here to there until your minerals are corrected, and you cannot get your magnesium to correct and potassium, because it'll keep leaking out of the cell. So what happens is people end up they you end up stuck. You're like, okay, wait a minute. Okay, so if you're unable to restore the mineral balance, the infrared will not work, because you need proper intracellular components to resonate that infrared. Obviously, it's going to be absorbed mostly by the copper, but it's also structuring the water. And the water cannot be structured unless you have enough ATP. The walls of the cells are stabilized by ATP as well. There's a lot of things that are going to cause a person. This is the classic person where nothing seems to work, right? Nothing's, and then we give up and say, well, it must be your childhood, or it's because you don't know. I'm here to say that there's a few key features that I was able
Dr.
to
Joseph,
I was able
let's
I was able, I was
summarize
able
it
to unravel
for
that
for the audience.
if we add these pieces to it, and
Right.
we see how this correlates with a urine pH. This is for
That's the problem. Correlation with urine is not going to work, because urine is being determined by the blood pH, which is strictly buffering it through the kidney. You cannot distinguish between acidosis due to the food that you're taking, or acidosis because of pathology through the
no,
urine.
this is the urine is not reflective of the blood pH. The urine is reflective of the lymphatic system, which
But
is
the urine will not reflect that. You cannot take the urine acidosis to be telling you
it's
this is
not.
acidity due to pathology or due to
Making
physiology.
you're not thinking in terms of acidosis. You're thinking in terms of an indirect way to get a feel for where your metabolism, how well is your mitochondrial function, your overall metabolism is, and to do that, you can measure the urine pH over time. Will show you if your urine pH is really low. I guarantee you that your metabolism is not. And here's the thing: what I found is that the buffering the redox, which is crucial, is not enough to correct the things I'm talking about, the mineral deficiencies. Why can I not get the magnesium and the potassium to normalize? Why? Well, I can tell you what I think. I think that what happened over the past, I think as the EMF has, on average, has risen, what it does, depending on each person's where they're at and their resilience and their hormones, all these different things, is triggering oxidative stress, like we showed with the calcium channels, which is causing oxidative stress on the mitochondria, causing mitochondrial dysfunction. At some point, you start to utilize glycolysis more, because your mitochondrial function is is suboptimal. And what happens, you start producing more lactic acid as a result. All right. And the if the metaphor I have is if you supply the antioxidants, whether it's NAC, glutathione, methylene blue, or even the polyphenols, is that you may improve things a little bit, but not enough to improve the loss of magnesium, the continued not enough to heal the cell wall and the receptor function in order to that the cell can maintain its crucial magnesium and potassium. Potassium, is needed to help with the zeta potential, right? It's the that's the part of the zeta potential being one charge on the outside of the cell and another charge which drives um, it's all part of how the cells receptors function and how things get in and out. That's one way to see it. But also, you cannot produce sufficient amounts of ATP if you don't have enough magnesium. But how can you give enough magnesium if the terrain, the cell walls are damaged? The magnesium is going to continue to leak out of the cell. So how do you fix that? That's what I'm talking about. I'm going to present something that has not been talked about. This is flavoring everything, not substituting. A concept that requires a looking into what if acid, the lactic acid that is increasing the acidity of the tissues and the interstitium is playing a bigger role than we thought, and that in order to and that the acidity also is building up in the cells. I mean, the lactic acid is being created in the cells, and that lactic acid is contributing to damage when it gets to too high of a level. Is contributing to to cell wall damage. Okay, and that is causing a leak, like leaky gut, leaky cells, leaky blood-brain barrier, leaky mitochondria. Okay, that we're losing crucial electrolytes that are needed for ATP stability and for membrane receptor function.
Doctor, can I just interrupt for a minute, or
Yeah.
you want to continue?
No. Go ahead. I'm eager to hear what you have to say.
Okay, I think you're right, but the basic thing is if you do what you're discussing is about the mitochondrial function and mitochondrial instability, and you're talking about the mitochondria, because lactic acid to pyruvic acid to the formation of the ATP is also the part of the Krebs cycle. And whenever there is everything what you describe is like potassium and magnesium and leaky membrane and all that's what happens when there is inflammation. So when you are talking about the integrity of the cell membrane, it is the integrity of the cell membrane is very essential in the maintenance of everything, in the potassium pump, in the magnesium, and then the extracellular, intracellular calcium, and TRP1 receptors. And this is what is important, and this was what gets disturbed in there when there is inflammation, acidic nature, and alkalinity. And that's why the alkaline diet, when we call about the alkaline diet, it is important in the maintenance of the part. But nothing, just like Dr. Halasa maintained, that you just giving the alkaline water is not going to change. And that is so true, that it's not going to change any and in the membrane potential. And when there is a leaky membrane, it's not going to work. And when there is a potassium deficiency, the membrane polarity is not going to be there. So it is essential that you maintain the cell membrane, the intactness of the cell membrane, and then gradually you are going to maintain the intracellular potassium, magnesium, and in 3 decades of my work, I have discovered that the recently the population has heard all these, and they know. And when you look at their blood test results, you see that their intracellular magnesium has increased because they've been taking large amount of magnesium orally, and we used to find large number of population which was deficient in magnesium. Now we see lesser amount of population with magnesium deficiency, but the potassium has not been corrected. Potassium has remained, and I think that that's where the adrenal is playing great part. Also, it's a cell membrane, but like patients, those who are on the treatment for for their autonomic dysfunction, and they have also the dysautonomia. And when we give them Florinef to maintain their blood pressure, the potassium is deficient in every single patient. So when we are talking about the cell membrane and the potassium, and not having any importance of urinary pH, it's they are all excreting large amount of potassium and not keeping it. And so no matter you give how much of potassium, you have to give very large amount of potassium for them to increase their serum potassium, increase their intracellular potassium, and maintaining their blood pressure, as well as the nature of them physiology to be better. So I think what Dr. Halasa is saying, what you are saying is absolutely true. But you have to first of all, it is very important to say that why do we see that? And when or acidic, when we have seen the alkaline diet, it's not that. And if you see that cancer treatment, the Virginia, they was doing the cancer treatment just by changing the diet, and they have reversed large number of patients having cancer. So I'm talking about now prior to what we are doing, and so that was absolutely on a vegetable juicing and certain kind of diet, and which was absolute alkalization. And we know that alkalization is very important, and try to maintain the pH around like 7.3, 7.4, not very high, because it is also very important that all the optimal enzymatic function takes place around that. If you try to go your pH around 7.8, it doesn't 7.8 to 8, it doesn't work. So similarly, when urinary pH goes high, you make patient more prone to develop the bacterial infection. So, or patient with the bacterial infection, they have a higher pH. So I think it is a very interconnected biochemistry of the body.
Yes, absolutely. And I just want to clear, I'm not talking about the alkaline diet by itself. I'm talking about 7 pillars, alkaline diet being one aspect to reduce the acid producing foods, whatever diet it is, because the acids are contributing to the issue, and that's not necessarily redox. Okay, I mean it's connected, but that's something that is if we see put it like this, a lot of the things that we're doing we don't realize are reducing the acidity to a level that is helping again, to get from here to there. I mean, ultimately, once you're perfectly healthy, I don't think that your urine pH of 7.3 to 4 or is necessary. But when you're trying to
We are not talking
what-
about urinary pH. We are not talking
Oh.
about 7.4 of urinary pH. We're talking about blood pH. Okay.
okay,
Okay. So
okay.
I want no. There's no way you want urinary pH around 7.3 or 7.4. You would want your pH to be at the most 6 or 6.1. Or but ideally it should be between 5.5 to 6.
You're talking about your urine
Yes,
pH.
yes,
Between-
exactly. You don't
And then
want alkaline
what
pH.
is urine pH represent to you? I'm just curious because it's measuring blood pH is not practical in an everyday.
I don't think that you are going to make patient measure better by measuring repeated urine
No,
pH.
it's because I haven't
Urine pH is just the indication.
I haven't given the lecture, so you don't know what all the aspects that I'm
All
bringing
is
in.
my years of experience, and
Yeah.
from that I can just say that the blood pH is if you want to, and the blood pH is also is a variable from time to time, depending upon, it's not going to be the same from hour to hour, because you are going to drink what kind of water you drink and what kind of food you eat. So it is variable. Not only that, it depends also on the microcirculation. It depends upon the mitochondrial function. And so
Okay. How
how
do
the
you know?
mitochondria,
How do you know that that's not a part of my lecture that I'm going to give?
I don't know. I don't know what your
Right.
lecture is.
No,
I'm just
that's what I'm trying to say is I don't want. I'm glad you spoke because you shed some light on alkaline diet. Now this isn't just alkaline diet. It is seeing through a lens that can shed light on how these certain treatments, some of them we already know, whether it's infrared, whether it's whether it is reducing the EMF, which is that's just a phrase unless you actually know what to do.
yeah,
Okay.
but what
It-
is the EMF do? What does the EMF
Yeah.
do? It works
What's that?
as a defender.
EMF is contributing to oxidative stress, which is contributing to acidity. And I thought that
But you are
cancer cannot grow in a non-acidic environment, right?
that is true, but you are it is not, it is the pH is the byproduct. Okay, pH is the byproduct, acidity is the byproduct of the cellular byproducts, and that is one of the things that you can look at and say, is there a problem? And
Yes,
where is the problem? And problem
exactly.
is that it is it's the metabolism, and metabolism is also part of the
Well,
you know
then that's
is
what
it,
that's what I was saying. We're using the urine pH to gauge our metabolism that we can have if we're not measuring the blood pH, okay, which is not practical, okay, to do an arterial blood draw and send it to the lab. That's not practical. I'm suggesting, and I'll get more information to describe what exactly does the urine pH, more details about it so that we can see it clearly. What if it's
glad to hear your answer,
what
but
if
I
it's
think
a generalized screen, because what you're doing from day to day to day matters. How do you know where you stand if you don't have any, you can't
Dr.
measure it?
Joseph, to make it easy for you, the problem with urine pH, if it's acidic, right? You don't know this acidosis is physiological or pathological, so the test cannot be specific. That's the
Okay.
problem.
Okay.
Now
What
you
if you
can come up with
what if you do it first thing in the morning? So you don't have any variables other than the fact that you slept. Then what? Then what is the urine pH? If it's really low, what is that? And it's really low every single day. What is that telling you?
Well, if you've
You-
been ill,
And you're doing all the things that you're supposed to do. It's telling you something
it
is
depends on
missing.
what you eat at night.
exactly.
Well, you're not supposed to eat at night because it's what we're talking about is fermentation. Okay.
Right.
When we talk about acid, what we're really talking about is some sort of
If you
gauging
don't
a measure.
eat,
You're
if you don't
measuring.
eat at night, listen, the problem.
No,
If you
no,
don't,
no. I'm talking about a measure. Okay, if you're gonna be one of those people that says you got to have a maintain a certain pH in general, cancer can't grow. How do you know what you're doing on a regular basis is indicating that you're moving in the right direction? Okay,
not
and
using.
it's more than, oh, I get it. I just don't have to eat at night. I won't have cancer. No, there's lots of things that play into the subtle fermentation process or degeneration process.
If you
And
don't eat at night, you will end up with.
when you see my lecture,
Yeah.
I'll break it down
Okay,
piece by piece.
let's
So that
wait for your lecture.
because that's why it's a paradigm shift. You're not going to see it right now until you see the things that are leading up to it, the dots that I can't
We
explain
agree with you,
by
Dr.
10 minutes. You
Joseph.
can't agree with anything with right now. I haven't given the lecture.
No, we agree with you with the principle of acidosis in the tissue is a bad thing, whether it's from the cancer or from inflammation. You have acidosis as part of it. We have the problem that, or the difference that we have right now. We cannot see it now. Maybe we'll see it when you have a lecture.
There's a cognitive dissonance.
Is
And
the
that's all
urine
I'm saying.
is the urine pH to be that specific diagnosis for the
Okay.
acidosis?
That's the problem right there. Either you're grabbing onto the alkaline diet and honing in on that, or you're focusing on the urine pH. You're not seeing it in the bigger context.
We
When I
want to
get the
learn
bigger
that from you.
context, yeah. Once you see the bigger context,
Right.
and what you're helping me to do, okay, this is healthy debate, is you're helping me to better explain why and define this gray area of what really is the urine pH telling you. Okay.
Right.
And why would it be, how could it be utilized to give you a marker on a daily basis on average, where your average is, okay, where you stand on invisible things that you cannot see. You can't measure the the intracellular potassium and magnesium every day.
Let me explain to you, Dr.
You
Joseph.
cannot gauge how good you're doing with your diet.
Let me cut you off here just 1 second, okay? Just
Yeah.
so we'll be on the same page. I'm not debating here to negate you. I want to hear your lecture. We want to learn from you, and you come up with brilliant ideas, and we appreciate everything your inputs here. But we also need to make sure, I don't want to be correct all the time. I all the time looking for people to say I'm wrong so I can fix myself. But the problem that we have, I want to hear from you, the pH of the urine, the problem with it is that it's not specific for pathology. It could be physiological. If you say you don't eat at night and you fast, then you will have breaking down your fat, you end up with ketoacidosis. Your urine in the morning will become acidic as well. How you can define that acidic in the urine is due to abnormal metabolism in your tissue, or it's because of the physiological process. So that's the problem. I mean, I would love to measure the tissue acidosis,
Yeah.
but we cannot do it with urine. It needs to be something else. But if you have your own way, saying maybe constant acidity in the urine every morning is indicating a pathology, okay, that's fine. What's the significant for that? And what's the data to prove that?
Yeah, exactly. And that's what you're helping me to define more specifically. And it may involve also checking it periodically during the day. Okay. And that I'm certain that there is a way to have an indicator so that you know with what you're doing is on the right track. Because if you understand the underlying principle, if the underlying principle is acceptable.
No, the
okay,
underlying principle is
the
acceptable.
underlying
Tissue
principle,
acidosis is pathologic, especially in case of relative cancer, inflammation. It's part of the pathology. We agree with you with that principle. The problem is
And-
that
and-
having urine testing to reflect the pathology of the tissue acidosis, it's a difficult to push because it's not specific and it's hard and it's not clinical practical. But if you
Well-
come up with a logarithm to explain maybe like heart rate variability concept where you have no heart variability, then that's a problem. You have sympathetic parasympathetic, it does not work. Maybe you come up with some logarithm there to explain to us that. But from my perspective, I don't see the significant behind it up to now until you present your lecture.
Yeah.
Maybe it will open up doors.
Not yet, unless
Okay.
until there's a paradigm shift. And
Okay.
I think what I have is the formation. I've
Okay.
got the formation of a major paradigm shift that needs some filling, some unanswered questions on that side of
Yeah,
things.
but urine for me right now is like not yet. You want to prove it, you have a logarithm, that's fine. Me and Dr. Patel, we agree urine cannot be the reflection of the tissue because it's not specific. That's the diagnostic testing has
Right.
to be specific,
And
right?
and what if it was done,
That's something you
what,
need
what
to
if it
prove
was
it.
done
Yes.
more than once in the morning?
I don't know. So that's
And certain readings over time start to reflect a basic fundamental measurement that is crucial. Okay, just take the urine pH out of it for now and realize the question is beneath insulin, is acid the catalyst, like a catalyst in a car or a transformer? Does that determine the voltage that causes the change in conformation of the insulin receptor
no.
that makes
No,
it resistant?
no.
Well, I'm bringing.
Yes. Let me tell you about this. Okay.
It's a catalyst.
Okay,
for,
let
for,
me
for,
let
for
me
stem
go
cells
ahead
that
to
are.
you. Okay, let me go ahead back to you. I have a problem with the doctor. His name is Berger or someone integrative oncologist, last name Berger, so something like that. And he was a big fan for acidosis with cancer and changing the acidosis of the cancer, which is yes. But the misconception happened with understanding of alkaline diet and misrepresenting it as it is has to do with the pH of the water. Now,
Well, that's a limited
yeah.
view.
So let me explain to you the insulin resistance.
That's
The
missing.
insulin resistance, the insulin resistance and insulin receptor sensitivity, it's not because of the pH change. It's because of oxidative stress and oxidation, rusting. Like car, it rusts. It's not because of acidic they get old, but because of reaction with
Okay.
oxygen they get old.
Okay, so acid isn't. There's no connection between acidity and fermentation.
No, there is no insulin.
Dr. Halasa,
Oh.
there is a fermentation does increase the acidity, and there is no question about that, and that is the reason I think all of us are right, but just to say that everything is acidic, everything is alkaline, everything is this. No, it is a balanced process. It's a
Okay.
balanced
Again, let
process.
me
Of
make
course. Well,
sure.
what I'm trying to do is.
Let me make sure.
What-
Insulin resistance, it's not because of the change of the pH or the acidosis. Insulin resistant, it's because of oxidation. Okay, and hemoglobin A1C, it's a glycan, it's oxidized glucose. LDL, oxidized LDL, at least it's oxidized. So this is the principle. Now, there is any correlation between acidosis and oxidative stress in the tissue? When they have oxidative stress, they are acidotic, as they have high acidity because the mitochondria, when it leaks the free radical, it leaks the proton. The healthy mitochondria pumps the proton all the way inside all the time, and there's
Yes.
right. So when you have leakage, you have leakage of free radicals, and you have leakage of of hydrogen, and yes, you have a tumor microenvironment that's acidic, and yes, they lead to cancer differentiation, they affect the immune system. But when it talks about insulin resistant, it's because of the oxidation of the insulin, and all the free radical generators could be from the toxins, mycotoxins, from heavy metals, from lipopolysaccharide, from leaky gut syndrome, from all this inflammatory cytokines that induces the NOx and the free radical gene expression, which is the pro-oxidant. Let's keep that concept as that for now.
Well, that's solid.
Right.
All I'm doing is answering the unanswered questions of where acid base plays into this, which is something I've always been curious about, and it sheds light on some of the things that basically are already the things that would make us a healthy person to begin with. But when you look, it's just looking through the lens of it's not in place of, it's not this versus that. It's showing how acidity is a part of this picture, how it's playing a role. And
Yes.
one of the things that is an issue is this difficulty in getting the loss of crucial magnesium and potassium and other ions that are leaking, leaking through the damaged
Yes, when
membranes.
you have acidosis,
And if you, it could be that if we also address acidity alongside oxidative stress, that 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 will make it easier to replete the minerals. And when those are not leaking anymore, that will allow for getting over a sticking point, or when somebody says they've done everything and nothing works, then you have it's another lens to look from that can be addressed. If we're stuck on just ketogenic diet and we're eating acid producing foods and we don't realize it, we may be that's just one example. Everything is not about alkaline diet. We may be inadvertently making it harder to get better because we are compromised to the point where we have to take a more drastic level to reduce acidifying foods, to reduce, come up with a better way to reduce EMF, to understand where structured water plays a role in this and how it's connected to minerals, and that if we and perhaps understand herbals and how they are maybe a more concentrated, absorbable source of minerals. Plus, they are non-acidifying, and if we start to kind of refine that edge of it, we may have a better, maybe easier to replete the intracellular levels of magnesium and potassium, which is crucial for the cell wall integrity and for ATP stability, right?
yes.
And as of right now, everybody I check, I was scratching my head. Why is their potassium, calcium level so low? Why is their magnesium so low? They're doing the magnesium sulfate baths. They're spraying the magnesium on their skin. They're taking ionic this or that. What am I missing? And that's where this shed light on things. And again, I thank you really, because this is forcing me to refine some of these things you're bringing up. I have to be able to answer them, and if I can answer them, I think we have something.
Right. I mean, I'd
But
like to
all
quickly.
this time, that's what we have emphasized. In our books, we have mentioned that cellular integrity of the cellular membrane, whether it is the mitochondrial membrane or it is the endoplasmic reticulum, any kind cellular and subcellular membrane, if you maintain their integrity, you maintain their electrolyte balance,